from Mumbai. He is an honorary orthopedic surgeon at Chafey Hospital, Nanavati Hospital, St. Elizabeth and Kambala Hill Hospital, Mumbai. He is also a panel consultant with ONGC. Sir has been practicing for more than 39 years and has been awarded the highest fellowship of SICOT to Italy in 1985. He is an instructor for AO courses since 1985, awardee of AO International Fellowship to Germany in 1995, winner of National Fellowships in 1989. He has been recognized as a professor in the University of Bombay. He is examiner for postgraduate students and he is a recognized inspector for recognition of hospitals for postgraduate teachings. He is also an editor-in-chief of International Journal, ASOR, editor for Journal of Orthopedic Science and Research, main coordinator for more than 48 cities of India, and moderator of Saturday night webinar CMEs with WS Rosemont, Chicago. Yes, we have Dr. KJ Reddy, sir, who is from Hyderabad, and he is also the co-director for this track. And sir is MS from PGI Institute, Chandigarh, and has done FRCS from UK and has got FRCS Orthopaedics also from UK. He is presently the senior consultant in orthopedics at Apollo Hospitals, Jubilee Hills, Hyderabad. He is primarily a hip and a knee replacement surgeon with special interests in primary and revision surgeries, sports and arthroscopic surgeries. He is professor and head of the department Orthopedics, SVS Medical College. He is medical director, SVS Medical, Dental and Associated Institutions. He is a president-elect for Indian Arthroplasty Association, elected unanimously in October 2014. Sir has received the first prize for Best Fracture Fixation, a regional AO workshop, Black Notley, September 1995, and has been an awardee of State Merit Scholarship for MBBS by the Government of India. With this brief introduction about both the course directors, I hand the session to them to take it forward. So thank you very much for being with us today and being host to this track. Over to you, Dr. Dilip Shah and Dr. KJ Reddy, sir. Thank you.
Going to play the video, no? You're going to play the video for 5 minutes, no? Then the program will begin, no? What do you want?
Yeah, got it.
That's what I'm asking. You're playing the video, no?
That has been done already in the background, sir. You can start.
Okay, fine. I need to share my screen, please. Can you allow me to share my screen? Dear colleagues, I am Professor Dr. Dilip Shah of Mumbai. For past 2 years, Best of Orthopedic Techniques and OTA has been a grand and unique forum for orthopedic surgeons to stay abreast with the latest developments in orthopedic trauma. We are live with OTA, Best of Surgical Techniques. I am going to be the course director along with Dr. KG Reddy from Hyderabad for track 6 on infections and non-unions, which is today, starting from now till 9 p.m. Indian Standard Time. We have eminent speakers like Dr. Kevin Tetsworth, a consultant staff surgeon, orthopedic trauma and limb reconstruction, Royal Brisbane and Women's Hospital, Brisbane, Australia, and Dr. Peter Johnidis, BSc, MB, MD, FACS, FRCS, Glasgow, and FRCS, England, Professor and Chairman, Department of Trauma and Orthopedic Surgery, School of Medicine, University of Leeds, United Kingdom, and President of Indian Orthopedic Society, Dr. B. Shivashankar, MS, D. Ortho, and Consultant Orthopedic Surgeon and Traumatologist, Iyer Orthopedic Hospital from Solapur, and Dr. Ritab Kumar, MBBS, MS Orth, and MCH Orth from UK, Chief of Trauma Services, Indian Spinal Injury Center, New Delhi, India. This academic extravaganza will bring together globally renowned speakers and most experienced Indian speakers to give you a learning experience. I thank you to have joined to participate and be a part of this innovative program and enhance your knowledge. Please feel free to ask questions in the chat box. The more questions you ask, more interesting it will be, and your query could be many other people's query who are reluctant in asking or afraid of asking. So please go ahead. I will announce that this conference part has started. I switch over to Dr. KJ Reddy, who will be giving his speech. Dr. Reddy, can you unmute and start?
Yeah. Thank you very much, Dr. Dilip Shah, for wonderful introduction and your kind words. We have exciting program. I'll just briefly go through the topics. Treatment and chronic osteomyelitis, an update by Dr. Peter Giannadis. Prevention aspects of orthopedic infections by Dr. Dilip Shah. Fracture-related infections by Dr. Kevin Tetsworth. Recent advances in PJI by myself, Dr. KJ Reddy. Pelvic infections and their management by Dr. Peter Giannadis. Case discussions, we will be, myself and Dr. Dilip Shah will be presenting, but the entire faculty will be participating. There will be panel discussion where all the faculty will be involved and the audience will have opportunity to ask questions through chat box. And again, lectures will start. Role of muscular technique in the treatment of infected non-union by Peter Giannadis. Exchange nailing in non-union of the proximal femur by Dr. Shivashankar. Contemporary treatment of infected tibial non-union by Dr. Kevin Tetsworth. Infection after fracture fixation by Dr. Ritab Kumar. New options to address segmental defects by Dr. Kevin Tetsworth. Case discussions and panel discussion follows this. So thank you very much for joining this wonderful, exciting meeting, and have a great time by active participation of everyone. Thank you.
May I request Dr. Peter to please go ahead with your presentation, sir. You can share the screen just now.
Dear Professor Shah, as the chairman of the session, dear esteemed faculty, I would like from England to express my appreciation for the invitation to all of you and the OTA for giving me the opportunity to contribute to this exciting educational extravaganza. You can see here the outline of my talk, and let's start with the definition and incidence of chronic osteomyelitis. It's a progressive inflammatory process which is caused by pathogens resulting to bone destruction and sequestrum formation. It has a bimodal distribution. Normally we see it in patients less than 5 years of age and adult patients over 50 years old. And the overall prevalence has been estimated to be about 22 patients, 22 cases per 100,000 inhabitants. Let's move on to classification and diagnosis now. The timing of presentation is one way we can classify osteomyelitis. So definitions of acute and chronic varies from 20 days to 6 months. So usually if it's the first 3-4 weeks, we consider that as an acute presentation. And if it's after 6 months, particularly after fracture fixation, then we consider that as a chronic presentation. However, you are all aware that the hallmark of chronic osteomyelitis is the presence of necrosis on bone during the histological examination. If we look now to other classification systems like the Czerny-Mader classification, it takes into consideration the anatomic type of the disease process, the physiological state and the characteristics of the host, the patient, and also a number of parameters, factors that can affect the physiological state, local factors and systemic factors. And it is not my intention to go through all this in the interest of time. In addition, we can look into the different types of osteomyelitis that normally comes to our clinics. So we are familiar with the presentation of vertebral osteomyelitis, periprosthetic infection, metaphyseal presentation, septic arthritis, diabetic foot infection, and osteomyelitis presenting after open fracture management. In terms of the diagnosis, we take into consideration the clinical signs of the patient and also the so-called biochemical examination, which includes a number of blood tests, particularly the infection markers, which usually give us an indication about the state of the underlying infection. A number of other proteins have been used, like cytokines, interleukin-6, TNF-alpha, and procalcitonin, but normally in our practice, we are utilizing the standard biochemical investigations. Imaging is very important. We must always obtain plain radiographs. CT and MRI, they are very helpful to allow us to evaluate the state of the bone in terms of the presence of sequestrum, but also the state of the soft tissues and the extent of the infection up and down, tracking the medullary canal, if we are talking about the long bone. And then we've got different nuclear medicine procedures that we can request. And lately, the positron emission tomography, the so-called PET scan, has gained popularity to assist us in the diagnosis of osteomyelitis. I would like to remind all of you that taking cultures from a sinus tract is not good practice. It may be deceptive, and therefore, I would recommend, particularly in chronic cases, always to pursue a bone biopsy. Let's move on now to the treatment modalities. The treatment depends on the duration of the disease process as well as the severity of the symptoms. You need to take into consideration also the presence of medical comorbidities, particularly in the elderly population. The main aim is to eliminate the underlying inflammatory process, which leads to destruction of the bone and the soft tissue and the development of discharging sinus. We need to involve the so-called multidisciplinary team. So you must have around you a plastic surgeon, a radiologist, a microbiologist, a vascular surgeon. Is a team approach to be able to deal successfully this difficult clinical entity. If healing has failed to occur, then we need to promote healing by optimizing the so-called mechanical and biological environment. And this can be achieved overall by the administration of antibiotic agents, surgical debridement, management of the dead space, soft tissue and bone reconstruction. And in terms of the bone reconstruction, we must be very familiar with regenerative approaches and techniques which currently exist in our armamentarium. I would like to submit to you that one of the very important evaluations during the treatment of this disease is the bone vitality. Unless we excise the dead bone secondary to infection, then the underlying defect which has presented as a result of the debridement will not be, we are not going to be able to restore the anatomy and to heal the bone that is missing. And therefore, whenever you are not sure, of course, there are different techniques to evaluate the state of the bone, the vitality of the bone. Any tissue which is precarious, which you are not sure whether is vital, it has to be excised. It's just like operating on a tumor. Unless you get healthy margins, then your treatment may fail. So debridement, it's the hallmark of a successful outcome. So let me share some cases with you now. This is a 32-year-old male with a 3-year history of tibial osteomyelitis. 5 years previously, he underwent plating of his tibial fracture at his country. He was from Africa and he immigrated to the UK. So you can see here the state of the soft tissues as well as the state of the bone from the X-ray of the tibia. The thickening of the periosteum, the destruction of the bone. You can see that.
Send the link on WhatsApp of questions.
You can also
see from the
see here the MRI scan of the patient, the extent of the infection up and down the intermedullary cavity. The patient was taken to theater. There was a bit of debridement where was the sinus, and then you can see here a rimming of the intermedullary cavity to remove the dead bone and the sequestrum utilizing the RIA device, the Rimmer irrigator aspirator. And then you can see the dead bone that was collected into the RIA filter. Some of this tissue can go to microbiology for cultures. And then we need to manage the dead space. And you can see here the Palacus cements with the appropriate thickness of K-wire, which help us to design and construct a cement rod, which was inserted for the management of a dead space, as you can see here in this video. And then you leave this for a period of time. It is also loaded with antibiotics. And at a later time, when the blood parameters have been normalized, you can remove the cement nail. And you can see here at 3 years follow-up, we had a very stable situation without any reoccurrence of the infection. Let's go now to a second case. This is a 50-year-old female smoker, had IM nailing of her tibia 8 years previously. 1 year later, the nail was removed due to infection. The fracture united, but developed discharging sinus. And then she presents to my clinic 3 years later, and you can see the state of the soft tissues. Dead bone is coming out of the sinus. This is the CT scan, the extent of the sequestrum. She underwent the radical debridement, cement spacer implantation to control the infection. We cannot proceed with soft tissue reconstruction due to underlying blood circulation, which was precarious. There was only one vessel. And you can see here, 2 years down the line, she had a very stable situation with the cement spacer left in situ, the state of the soft tissues. And since she was diagnosed with CA of breast, we didn't proceed with any other reconstruction. We have given our opinion about how to manage this difficult disease in chapter 28 of Rockwood and Green. So all of you that you would like to know more about what kind of surgical technique, what kind of local antibiotic delivery systems, how to manage the dead space and how to manage the subsequent bone defects, this is a great educational book to visit. Everything is there. And finally, I would like to remind you that in very, very chronic conditions, you always must remember the potential of malignant transformation of the chronic osteomyelitis. And in this case, as it was in this case, you need to do biopsies, you need to evaluate the degree of destruction, and usually the treatment here is amputation. So to conclude, management of chronic osteomyelitis remains challenging, requires a multidisciplinary approach. Treatment should be tailored to each patient according to the severity and duration of symptoms, as well as to the clinical and radiological response to treatment. A combined antimicrobial and surgical treatment should be considered in all cases, and relapse can occur, which has a major impact on the quality of life of patients, and is a substantial financial burden to any healthcare system. Thank you very much for listening.
Thank you very much, Peter. That was wonderful talk. We will have questions. Presently, I can't say any questions. We will go on with the next lecture by Dr. Dilip Shah. Is going to talk on preventive aspects of orthopedic infections. Dr. Shah.
Thank you very much for inviting me, and I'll share my screen. Thank you very much for a wonderful lecture, and I'll try to speak to you about prevention of infection in orthopedic surgery. Prevention of infection in orthopedic surgery, I'll be talking to you because I always feel prevention is better than cure. Once you get infection, it's a disaster. And if you compare which surgical branch has maximum infection, orthopedic stands second. Like in COVID also, we may be first or second in the world. Now, what infections could be there? Primary arthroplasties like hip and knee has 0.8 to 0.9%. Elbow arthroplasty for some obscure reason has 3.6. Femoral osteosynthesis has 3.9%. Pin tracks, because they are exposed to exterior also, they have 7%. Foot and ankle surgery 1.6. Alex valgus 1.3. And if you see scopies also, they have 0.1 to 0.4% infection. Open fractures, grade 1, Gustilo and Anderson has 0.9, grade 2 has 1.9, and grade 3 has maximum 12 to 53%. And amputation stump could be because of diabetes also 5 to 22%. So there is a strong need to prevent surgical site infection, and the risk is almost 1 to 3%. So apart from patient endogenous factors, role of external risk factors in pathogenesis of SSI is very well recognized. It cannot be overemphasized. Among the many measures to prevent SSI, only some are based on strong evidence. For example, adequate perioperative administration of prophylactic antibiotics. And insufficient evidence is there to show whether one method is superior to other. So, need for a multimodal approach involving active post-discharge surveillance as well as measures at every step of the care process, ranging from the operative theater to post-operative care. So I'll divide into three parts. One is pre-operative measures, other one is pre-operative and intraoperative measures, and third would be post-operative measures. Peri-operative measures could be like patients should take a proper bath. It could be good with some good soap. There is no need for chlorhexidine that has been studied. So a Cochrane review, including 6 trials of 10,000 participants, found no evidence of superiority of pre-operative bathing and showering with chlorhexidine. So that's not necessary. Decolonization of mupirocin ointment for prevention of Staphylococcus aureus infections. Those who have nasal infection of Staphylococcus aureus, intranasal application of mupirocin reduces the burden of infection from 2.3% to 0.3%. So it's very important. And ESBL, extended spectrum beta-lactamase colonization, and impact of antibiotic prophylaxis. Gram-negative does not happen in routine surgeries, but those who are prone or those theaters have some problem, then aminoglycosides or extended spectrum beta-lactamase should be used. Optimal timing of pre-operative surgical antibiotic. Surgical antimicrobial agents for prophylaxis that definitely reduce the rate of infection, and it goes to 1.1 to 3% instead of 4 to 8%. It should be administered half an hour to 1 hour prior to the surgery before incision. Hair removal, you should not do it on the previous evening, but the study shows immediately before surgery, or if you don't have too much of hair over there, it is discouraged to do shaving. Antimicrobial skin sealants, we are very much fond of using it, but the study shows it should not be used at all. Surgical site preparation, it can be done with 2% chlorhexidine combined with 70% isopropyl alcohol which seems to be superior to 10% povidone iodine. Chlorhexidine, some people have gone to the extent of going up to 4%. Recolonization of skin bacteria over time needs to be respected, particularly during long operative procedures. So if need be, you may administer another dose of antimicrobial agent. Scrubbing either with suitable antimicrobial soap and followed by suitable alcohol-based hand rub before donning your sterile gloves. Ideal duration remains unknown, although it is probable that minimum duration of 3 minutes by stopwatch is important for doing your scrubbing. Preoperative and intraoperative measures enhance nutritional support. Those who need the support, arginine, glutamine, omega-3 fatty acids, and nucleotides build up the hemoglobin to around 11 is very important, and perioperative discontinuation of immunosuppressives is not recommended. In fact, those who are on immunosuppressives, they should continue with immunosuppressives. Perioperative oxygenation. During the surgery, if it is under general anesthesia, 80% fraction of inspired oxygen intraoperatively and if feasible in the immediate post-operative period for 2 to 6 hours is absolutely essential. In today's time also, where we have oxygen lack in our country, it is mandatory that at least maintain for 6 hours. Normothermia is very important. You may use it by electric blankets, and what temperature should be maintained, but keep it around 37 degrees. Use of protocols for intensive perioperative blood glucose control for both diabetics and non-diabetics is very, very important. Maintenance of adequate circulating volume control, maintain normovolemia. Drapes and gowns should be sterile, disposable, non-woven or sterile, reusable woven drapes and gowns. Plastic adhesives, which are incised drapes with or without antimicrobial properties, should not be used. This is the recommendation. Saline irrigation of incisional wounds before close. There is insufficient evidence for this, and you may give a wash with povidone iodine. Antibiotic incisional wound irrigation should not be used. This is the study by the Global Infection Committee by WHO. Negative pressure may be a VAC therapy, negative pressure wound therapy in adult patients on primary closed surgical incisions in high-risk wounds is pretty good, and whenever you cannot close it, it's always better to use NPWT or VAC therapy. Surgical gloves, it does not show that 2 gloves are better than 1, but it's always better because the outer glove generally gets injured and a right-handed person's left-hand glove gets some brunt of the injury. So keep on changing the gloves from time to time, outer gloves, and if you feel it has pierced the inner one, you may change the inner ones also. And use of triclosan coated sutures. The superiority of this is not so much well perceived, but if you want to use it, you may use it. Laminar airflow by study in Germany and New Zealand confirmed the absence of SSI reduction with laminar airflow. So now it's up to you whether you want to use laminar airflow. But what is mandatory is ultra clean air group, use HEPA filters. Using of UV lights. You may use UV lights prior to your entry and your personal entry, which reduces the infection rate to a great volume, and what is required is 25 to 30 mWs per centimeter square. All exposed skin should be protected, and it is recommended that the operating team wear 2 caps, visors, and occlusive clothing if you are continuing with the UV lights. Post-operative measures. Systemic antibiotic is not recommended post completion of the surgery. Moderate quantity of evidence from high number of RCTs have shown no benefit in reducing SSI after surgery when compared to a single dose. So your habit of continuing for pretty long should be deferred. Advanced dressing over a standard dressing has no superiority. Antimicrobial prophylaxis in presence of a drain is not allowed, and wound drain should be removed when clinically indicated. It's your sixth sense which tells you when to remove the drain. I will go through a difficult slide. We start from 9 o'clock position. If there is susceptible host like cancer patient, elderly patients, surgical patients, burns, diabetes mellitus, then break the link by treatment of primary disease and recognize the high risk patients. If there is a patient with infection agent, bacteria, virus, fungi, protozoa, parasites, please try and understand and break the chain by prompt treatment, decontamination, rapid identification of organisms. If there is a reservoir problem like people, equipment or water, break the link by good health and hygiene, environmental sanitation and disinfection and sanitization. Portal of exit, excretions, secretions and droplets, break the link by proper attire, hand hygiene, trash and waste disposal, control of secretions and excretions. And if there is mode of transmission through contact, droplets or airborne or vector-borne, then break the link by hand hygiene, airflow control, disinfection, sterilization, proper food handling and isolation precautions. And lastly, portal of entry, respiratory tract, GI tract or genitourinary tract, mucous membrane, skin. Break the link by aseptic technique, wound care, hand hygiene, catheter care. This is how you're going to break the chain. And as I've been always saying, that wound challenges in orthopedic situations are very difficult. Let's stick to only Gustilo and Anderson type 3, which is the most difficult one. This is type 1 here, 2, 3A, 3B, 3C. You must take care if there is compartment syndrome, and how compartment syndrome is going to be a disaster. You must keep in your mind, and you must do a total compartmental decompression by a good method. Like this is the leg, and you go from the fibular aspect. This is increasing of the compartmental pressure. So your incision go right into the muscle plane and go up to the fibula, and then decompress the pressure which has built up in this compartment syndrome. You will save many limbs by doing this. Whenever you have a 3B injury, then you must do an extensile longitudinal skin incision, get rid of all the dead material. You may stabilize by external fixators like a ring fixator. When it comes to 3B, there are people who believe in nailing, some people believe in external fixator. But if you have possibility of nailing without reaming, or you may use the reamer just to find out what could be the diameter of the nail, that will help you because it helps you in dressing pretty well, and healing also can happen very well. So for wound management, wash for minimum 8 liters of normal saline, and if it is oily, then use cetavlon, hydrogen peroxide, antibiotics, anti-inflammatory analgesics. And if you have a mangled extremity, then transport with a splint as a primary. Complete wound management, same as compound fracture. Remove all tissue which is dead and devoid of vascular supply. Amputated part should be wrapped in plastic and kept in ice. This point has to be clarified to the general masses. Identify and ligate bleeding major vessels and leave the ligatures long for further identification. Maintain strict aseptic precaution and give splint after dressing. This is a long, busy slide. If you have time, you can take a screenshot. I'll wait for 2 seconds further. Take a screenshot and follow this kind of protocol. This is a fresh injury where you have to pay attention to first vein, artery, nerve, tendons, and bone. This is how it can be beautifully reconstructed, like God had created, maybe almost same. In such kind of extremities, go till you feel whatever is dead should be removed. What you feel more than that, only preserve vascular structures and which are very vital one. You may initially stabilize with whatever best method you have, stabilize them, and then definitive treatment can be done. You may do primary skin graft if it's possible, otherwise wait. Your plastic surgeons can help you in doing a flap surgery. Debride very well so that you will not repent later on and cause infection. This is the best way in which you can close any wounds, or if there is initial infection, a VAC therapy, negative pressure, which will make you heal very well, and all the infection can be controlled. Because as we always say that I treat and he cures, the God cures. But I tell you that if it gets infected, then I will treat and I will cure should be your motto. So I thank you very much for your patient hearing, and I'll stop sharing my screen. We'll keep the questions at the end of it, sir.
Yeah, I think presently I can't see any questions. That was a wonderful talk, Dr. Dilip Shah. Presently, I can't see any questions in the chat box. So we'll invite the next speaker, Dr. Kevin Tetsworth. He's going to talk on fracture-related infections. Kevin.
Okay, hopefully I am sharing my screen. And if you can see, that's good. Many thanks to the organizers for inviting me to speak. I think this is an exciting topic, and I'm sure that all of you that are listening and participating should benefit from participating with us. This is a common sort of problem that we all see and everybody treats. And I'm going to run through some of my thoughts on where we are going with this. I work both in Brisbane and in Sydney, 2 different centers, and we'll go from there. Mandatory disclosures, none of which relate to this presentation, and I won't go through this for the rest of the talks I give. Now, this is a quote from a Chinese military strategist 2,500 years ago that you must know both yourself and the enemy, otherwise you'll succumb in every battle. And really, this also applies to how we approach orthopedic infections. You need to know what your capabilities are, as well as what you're fighting. Now, for those of you, I know there'd be some of you in the audience or some of the other panel members and things that also participated in the International Consensus meeting in Philadelphia. This is also a tremendous resource, and I would encourage you to go to this icmphilly.com. But this also gives you lots of information, and it's all in the form of these questions. And so this was Jay Parvisi put this together with Thorsten Gerke for some period of years now. This was the second time this was done. Every 5 years we get together. And one of the first questions was, should hardware be removed when treating surgical site infection in orthopedic trauma? And again, we tried to address 650 different questions, so it was quite an undertaking. But Tracy Watson answered this, and I believe this was the single best written answer in the trauma section, but I think he missed something. And he went into a very nice discussion saying that you can retain the hardware based on the timing, meaning the duration of how long the infection has been there, and the stability, with the emphasis being that once you've lost stability, fighting the infection is impossible, and then the hardware needs to be removed. As long as it is stable, the implication is that it can be retained. So very early on, and with stable implants, you can retain implants, and that was a big emphasis of his discussion. Now, what's the most appropriate management of very early infection with stable infection? And most people would say giving the IV antibiotics, and this was put together by Janet Conway, Martin McNally, and things. Both of these answers also miss an important consideration, and there's more to it than just time and implant stability. And so what I'm going to do is continue moving along. We have a lot of ground to cover, but I will get to what I think is the important issue and add to the discussion that these experts have already put into their answers. And so, what do you recommend as suppressive therapy? They should be culture specific. These are all things that people have known for many years. This is not really new information. You identify the organism, yes. You give them the right antibiotics. And when you try to add something new to the picture, what it is that you need something to fight biofilm. And there are specific biofilm active agents. And this is the factor that people have been missing. And I think that for gram-positive organisms, there are biofilm active agents, and the main biofilm active agent for a gram-positive organism is rifampicin. And the main biofilm active agent for a gram-negative organism is ciprofloxacin. And so you need to add this, and really covering with a single antibiotic is old school. Now we give multiple antibiotics, 2 or more antibiotics simultaneously, even for a single organism. And this was the only big study that's looked at this, but about 233 patients, of which 122 were acute fractures, 90% success in this approach, adding rifampicin as another antibiotic. And also adding ciprofloxacin for gram-negative pathogens. So far, it's the largest study that has been done evaluating this sort of approach for debridement and retention of implants in the face of an acute infection after fracture, so fracture-related infections. Now, my friend Andre Tampuz has been a big advocate of this as well, and he has the Pro Implant Foundation. That's something else, another good resource that you can visit out of the Charité Hospital in Berlin, and also advocates this kind of suppressive activity, adding rifampicin for those organisms that are sensitive to rifampicin. So you need to work together. We work in a multidisciplinary unit in Brisbane. We work together with the microbiologists, with the infectious disease. We have a interdisciplinary meeting every week, together with a multidisciplinary clinic, and it's together with plastics, orthopedics, microbiology, pharmacology, and infectious diseases. A very important consideration. And finally, there's also this other aspect of it's very difficult to fight any infection if it has an IM nail retaining the implant. So you are more likely to need to remove a nail in the presence of an acute infection than plates. Now, to summarize my approach to this, I have put together a little bit of what I think of as an algorithm. And so you need to consider the gram stain status. Are they positive or negative? If they're positive, are they sensitive? Is it sensitive to rifampicin? If it's gram negative, is it sensitive to ciprofloxacin? The host you also need to consider, the A host versus B host. I was George Cerny's fellow. You've all heard of the Cerny-Mader classification of osteomyelitis and orthopedic musculoskeletal sepsis. And so there's this A host and B host designation. That's another consideration. So first the gram stain status, then the host, then what is the organism? Because you still want to make sure that you have a sensitive organism and it's sensitive to a biofilm active agent. Then there is the stability issue that other authors, Tracy Watson and others, have already advocated, making sure it's a stable implant, and then you are more likely to be able to retain it. And then time, and I have arbitrarily chosen 10 days because by 9 days already you are beginning to form biofilm. That is just a fact of life, that biofilm forms very early on. So you need to consider all these things, the gram status, the host, the organism, the stability, and the time. And if you put that all together, and I like to think of it as a ghost protocol, and that may be, a foreign concept to you, but this is a Hollywood movie starring Tom Cruise, and I'm sure some of you have seen this movie, and it's a good way to think about it and remember it, is just think of the ghost protocol, and GHOST. And now, I have given these lectures on orthopedic infections for 30 years, honestly, hundreds of times. And so I get at the end of the talk, I always get the same questions, and it comes down to how many times should I repeat the debridement? And the answer is as many times as it's necessary to get it right. In my hands, it is once, but in your hands, it may be more. You need to do it as many times as it takes to get it right. How do you know dead bone from live bone? And Peter emphasized this earlier, how important this is. The quality of the debridement determines your success or failure. So this is direct vision. You need to look for non-bleeding bone, and you become better with greater experience. And when do you close the wound? If the debridement is excellent and complete, it is safe to close. I close every wound I can every time, or I get plastic surgery to assist, or myself swinging local flaps, or they put free flaps on. And I will give you this one tip, that your phone sees better than you do, certainly in infrared. So take a digital photo with a flash. The dead bone becomes more obvious in the photograph. Now, this is a very typical kind of infection case, and we'll run through it very quickly. Unfortunately, these things always fall to the most junior surgeon, the least experienced guy available. In the public hospital, it's a non-trainee. In the private hospital, a brand new consultant. And it's always added on at the end of the list. I cannot stand this, but this is what happens, and it's done as an emergency out of hours. People are rushed. They want to go home. They don't have good imaging. They make poor decisions, and I think they often do more harm than good. And if you use the term washout already, it makes you suspicious in my eyes, because that is what happens with my laundry. I do the washing. So scraping the bone, these are concepts that are so far outdated, they need to be removed from our lexicon. This should not be the way we describe management of an infection, a washout and scraping the bone. And believing anything, this is not a religion. You need to know. This is knowledge-based. We make decisions based on knowledge, not a belief. Now, again, we're going to look at these characteristics, gram stain status, the host, the organism, and whether or not we retain the implants. And so this, I let my fellow do this case just to see what it is that another orthopedic surgeon does. It's different from me. In my hands, I get over 98% success. So I wanted to see what was done different. I emphasized to him the need to measure on the x-rays, and we look at the x-rays, we measure the distance from a fixed point. In this case, it was the ankle. We went from the ankle 110 millimeters and 150 millimeters and said, there is an area of bone there, which looks like a sequestrum in this case. And he said, boss, I can't see anything. I said, it is there. You need to find it. Keep looking. He moved about 3 millimeters, and out pops a dead fragment of bone. So the fragment is there. You need to just find it. And I think that localizing and measuring these things out to the millimeter is an important point. This is after his debridement. He removed more fragments of dead bone, put some beads in there. But you can see, I think, even looking at it now, in the infrared photo that you see there, in that photograph, you can see a bit of dead bone. Now, we also measure the volume of the bone defect to within a millimeter using saline. You need to know how much bone graft you need in the second stage. So there we have a defect. We filled it with antibiotic beads, local antibiotic delivery, very important. We always get a post-op CT scan to assess the remaining bone stock. And as long as 70% of the original cortex, including the fibula, is intact, it's unlikely to fracture. I also use it to do a critique of the debridement. And so there, in this case, this was done by my fellow, there's some residual debris. And it is always in that same location on the anterior side. Why? Because when the surgeon stands on the side of the table and looks across, his vision misses that area always. You need to get down low and look up in that direction. All right, I did a root cause analysis of the reasons for failure, and I'll try and run through this quickly to finish on time. I appreciate that everyone's time is valuable, but we looked at the reasons why things fail. And I looked at 132 consecutive cases that people sent to me that had been treated elsewhere by other surgeons that failed. And this, you know, we see a lot of infection. Everybody does. You all do. Everybody in the audience sees infection all the time. 30% of all acute activity at our hospital is related to infection. So during the course of a trainee's lifespan, during their training, they'll see about 3,000 infection cases. So why do we still have infections? Why is it still a problem? And I looked at all the various issues, and infectious disease issues was only 34 out of these, 260 something odd, 262 different reasons that I identified in these 132 patients. So 228 of them were surgical technique or decision issues. Inadequate debridement was by far the single greatest problem that contributed to treatment failure. 6.5 times more important than infectious disease. I mean, it's not the organism, it's not the host, it's not delivering the antibiotics. It is your surgical technique. And that is the reason why these other surgeons' treatment failed, and it came to me. So when do you retain the hardware? You need to know the nature of the organism. Is it sensitive or is it resistant? The nature of the host, A host versus a B host. Implant stability, stable or loose. Time, less than 10 days. Arbitrarily, I've taken 10 days or more than 10 days. Any of those things make it much more likely to fail. Meaning if you have resistant organism, likely to fail. B host, more likely to fail. Loose implants, it is already failed. More than 10 days, more likely to fail, because the biofilm is already adherent by 9 or 10 days. We always use local antibiotic spacers. You need to put them in. And I believe they're possibly more important than IV. And once you've reamed out a tibia, you've destroyed the blood supply inside that tibial canal. You must put an antibiotic spacer, as Peter showed you earlier. So there's only a limited number of reasons why things fail. Why do they fail? Inadequate debridement, compromised host, poor soft tissue coverage, resistant organisms. But again, when I looked at it, 132 consecutive cases of treatment failure referred to me by other surgeons who had already operated on it, 99.1% of the time, they had performed inadequate debridement. They hadn't taken out all the hardware, they'd left dead bone. So this is a surgical condition. Chronic orthopedic infections are a surgical condition. They use medical management to support your interventions to address the immune deficiencies, but the quality of the debridement, as Peter told you before, the single most important consideration. This is technically demanding. It requires some complex decisions, and it requires the most experienced surgeon available, not the least experienced guy. The most experienced surgeon should be dealing with infections. Again, remember this GHOST protocol. I won't belabor the point. We're running short on time, but these are the important considerations that you must consider every time. And George Cerny taught me this. You begin with the end in mind. You have to have some direction you're going, and you have to know what your expected outcome is in order to reach your goal. So match the patient with your treatment option and recognize your strengths and your limitations and get other people involved as you need to. Thank you so much for listening again.
Thank you so much, Dr. Kevin Tetsworth. This was really worth it. a wonderful lucid presentation, and it has told everything. Now, Dr. KJ Reddy, it's time for you that you tell us something about periprosthetic infections. Your time starts right now, and please go ahead, sir. Shoot, unmute yourself.
Good evening once again. I'm going to talk about, just a minute, I think, periprosthetic joint infections, which is a nightmare for every orthoplasty surgeon. So what can we do about it? So total joints in US is about 620,000 total knees, 310,000 total hip arthroplasty. About 27,000 revisions are done for PJI. This was data collected in 2013. So it's very significant number. Long time back, 1979, Sir John Chonley suggested that joints sepsis will be a big problem in the future. And PJI has got high morbidity. We can lose limbs and is comparable with some of the cancer, the survival, 5-year survivorship. I think I had opportunity to share the dais and give lectures to Parveji. He has done a lot of work on it. And one of this article is excellent. I think most of the people should read who deal with orthoplasty. The problem with the PJI is there's no absolute test for diagnosis, no standard definition or criteria. Culture is the gold standard. It's inexpensive. Results can be used for further testing, but it has got its own disadvantages, especially with false negatives. This is the new definition, working group of Musculoskeletal Infection Society. If sinus tract is communicating with the prosthesis, definitely infection. Positive cultures, at least 2 separate tissue or fluid samples from the same joint, positive, or existence of 4 of the following 6 criteria, then it is more likely dealing with the infection. Biomarkers, a big role, but I think still limited and experimental stage. If you have a strip like a pregnancy test or one of the urine strips, it would be great, but we don't have that simple test. Molecular markers play a big role, but it's a limited, expensive, still experimental stage. Microbe detectors, rapid detect, also useful. The biggest problem with the culture negative infected joints, where we cannot isolate organisms. The common cause in India especially is most of the people, when they present to you, they already on antibiotics without culture sensitivity. So we should stop antibiotics probably 1 week to 10 days and collect samples again, which will lead maybe positive results. As I think Dr. Shah was telling about decolonization of the nose will prevent the infection rate. New antibiotics, it would be nice we can have antibiotics similar to cancer medication, where they have they can reach the receptor area and high concentration where the infection or mycobacteria is there. Unfortunately, we don't have one. Biofilm disruption, if you have a technology where we can disrupt the biofilm, then we would be able to solve most of these infections. Vancomycin tethered implants might reduce the incidence of infection. Something like this in the introp, where you can see gross pus, there is no doubt about infection, but you must send for microscopy as well as cultures. My advice would be you collect samples from 5 to 6 different areas within the joint. I collect from femoral side, tibial side, suprasynovium, back of the femur, back of the tibial component, as well as femoral component. So you have chances of isolating, identifying the organism. What are the treatment options? You can do antibiotic suppression, debridement, excision orthoplasty, arthrodesis, debridement with the retention of prosthesis, partial revision, single stage revision, 2-stage revision, or multi-stage revision or amputation. Gold standard is 2-stage revision because it has got highest eradication of infection, 2 chances at debridement, and interval period where you can see the response of the host to the antibiotics, and it also allows you to plan for the reconstruction if there is a significant bone loss. There's so many studies which show excellent results following 2-stage revision for infected joints. This is debridement, antibiotics, and implant retention. We have good result for immediate post-op patients where implants are well fixed. And because for these patients, if you say immediate revision, they will be very upset. So this is 2 procedures are done in 1 stage. That means you debride everything, redrape it, and chain the insert and retain the implants. This is the little algorithm where you have a plan for early hematogenous and other types of infections. Single stage revision, where you remove all the implants, redrape and new instrument set, treat. Single stage revision, new prosthesis, consider antibiotic loaded cement along with local antibiotics, which are very useful. And local antibiotics can be added in a variety of forms. The success rate is about 90%. Remember, you're doing 2 operations at 1 stage. That is removal of implants and re-implantation as a second new surgery. And it should be very selective for a single stage. Organism should be known, sensitivity should be known, appropriate antibiotics should be available, and you can use antibiotic loaded cement, and it should be non-immunocompromised patients, healthy soft tissue, minimal bone loss. You must use IV antibiotics maybe up to 2 weeks and must continue up to 6 weeks, maybe longer if required, based on ESR and CRP monitoring. Systematic review says not much difference with the 2-stage or single stage. 2-stage revision, as I said, is gold standard for all complex cases, especially immunocompromised patients with systemic disease, concurrent sepsis, reinfection, where there is a significant bone loss, the organism, especially MRSA, polymicrobial infection, and especially when there is no organism, you have to do 2-stage revision. Of course, all complex cases. And I'll show you some of the cases. This is a 59-year-old, 2 months post-op. As you can see, pus is pouring out once you open the knee joint. This is inside the knee. And there is no way you can reach bottom of this implant with the debridement. So you must take the implants out. That's after removing the implants. As you can see, this is a spacer, cement spacer, handmade cement spacer. There's a commercially available spacers are available, which are expensive in India, but you can use this indigenous spacer. It will give some range of knee movements, maybe up to 30 degrees, which will give flexibility for the tissues. So for you, easy to expose at second stage. So this 2 months later with the ESR normal, CRP normal, gone in and revised into second stage with the revision implants. This is interesting one, 60-year-old lady, 1 year post-op, pain and stiffness. One of my physician's mother raised ESR CRP. As you can see the X-ray, there is a significant periprosthetic erosion. Once I open, there is no significant pus inside, but you see tissues like this with the significant erosion. That's a tissue collected. No obvious necrotic or pus in the knee joint, but a significant bone loss, as you can see here. So I treated as a 2-stage revision, and the culture came back as Candida. In India, especially, Candida is common. Mycobacteria is common, especially atypical mycobacteria. So you must send cultures for routine cultures, anaerobic bacteria, Candida, and mycobacteria, including atypical mycobacteria. That's my standard protocol. And this is the knee with a spacer in. And when we went in after treatment with antifungal medication, you can see nice granulation tissue and revised into 2nd stage. That's the X-ray. We published this one in 2013. These cases, you can see that's the scar, and she got reasonable range of movements. Most of these might have a little bit of extension deficit. That's a fixed flexion, but she got good range of movements. And this other case where you can see a sinus, 65-year-old male, 1 year post-op, treated with a 2-stage revision again with implants. As you can see, other side, severe osteoarthritis. Unfortunately, he couldn't come back to TKR for the other side because he was worried about the complication in the first instant. You can see this is the X-ray, 2 LES. Most of these people, chronic infection, they end up with some degree of fixed flexion, 5 to maybe up to 5 degrees, but it doesn't bother them much. Chronic infection, something like this, you may have to do tibial tubercle osteotomy. Otherwise, exposure would be difficult. You might avulse tibial patellar ligament, which would be a disaster. So you do elective tibial tubercle osteotomy and revise into revision components. This is similar to hips. This is another one lady with 51-year-old female. 2 years ago, the hip was done. Post-op dislocation, couldn't do closed reduction. Open reduction was done, which ended up with infection. She presented to me with a infected sinus like this, with X-ray like this, close-up of the X-ray. They tried to remove the implants, but still you can see it's a stabular component as well as the cement inside. So I took the implants out, cement out. This was done about 16, 17 years ago. And this is the 3 months later. I did the other side. You can go back and see there is DDH. I think probably surgeon did not realize that was the reason why it's dislocated. I revised, I did a primary hip arthroplasty other side using a corticocancellous bone graft and did the revision on this side 4 months later, and 9 years for more than, I think there's now 17 years follow-up. She's doing completely pain-free. And in India, most of the time we get hemiarthroplasties getting infected. So this is one of those where treated removal of the implants and using a cement spacer. This is also handmade cement spacer with a Steinman pin. I use those uncemented stems plastic wrapper and pour the cement to it so that you get a nice shape, like something like this, with the Steinman pin inside. So you can insert. It's cheap. You can make yourself. So this was taken out and did a uncemented. You can do cemented, uncemented, and you can go on for hours for debate. But this was suitable for cemented, so I did cemented. 1 year post-op, no recurrence of infection. So take home message, as Dr. Shah said, prevention is the key. You can do acute cases, debridement in well-flexed implants. You can do partial retention, single stage in selective cases where you know the organism, 2-stage interval based on the recovery, and this interval gives you freedom of reconstruction, and 2-stage is a must for where you cannot identify or isolate the organism. Thank you very much for your patient listening.
Reddy sir, this was phenomenal, and in short, you have told us one should not attempt arthroplasty if you are not well versed with revision arthroplasty. At the same time, you should not venture arthroplasty if you have no solution or you have not learned the art of treating infected joints. That was wonderful. May I request Dr. Peter sir, please go ahead with your presentation, and time is yours now, sir. Please let us have more knowledge from you.
Great. Thank you so much, Professor Shah, for the invitation again. The next topic is surgical site pelvic infections and their management. If we look into the literature, overall, in our discipline of trauma and orthopedics, the surgical site infection incidence has been reported to range between 1 to 3%. And if that develops, then we all know the consequences in terms of a prolonged hospital stay for the patient, increased healthcare costs for the healthcare system, but also for the patient, impairment of his overall physical, mental, and state and his social activities. Now, if we focus now into the pelvis per se, and we try to identify predisposing risk factors for the development of pelvic infections, I would like to submit to you that in the list we can include high energy trauma, soft tissue extensive damage, extensive surgical approaches, lengthy procedures, a patient who is in an immunosuppressive state because of the increased injury severity score, the presence of other associated injuries besides the pelvis. Massive blood loss can also induce an immunosuppressive state, and also prolonged stay in the intensive care unit environment increases the risk of potential development of pelvic infection. Other important factors that we need to take into consideration include arterial embolization, retroperitoneal packing, internal degloving, the so-called Morel-Lavallée lesion, urogenital and bowel tract injuries, and obviously open pelvic fractures, which usually present with this type of injuries. Now, interestingly, if we look into the literature, the evidence, the incidence of publications referring to pelvic infections remains rather poor, is limited. For this reason, I decided to carry out an extensive retrospective review of my practice, a review over a period of a 12-year time scale, where all consecutive patients who underwent any kind of surgical management for pelvic injuries and developed surgical site infection were eligible to participate. Exclusion criteria were patients that presented with pelvic osteomyelitis, not surgery related, superficial X-fixed pin site related infections, and patients lost to follow-up. The definition for SSI was superficial and deep organ space. We collected and analyzed data related to the patient characteristics, as you can see here, to surgery characteristics, the type of surgery, the time elapsed between injury and the procedure, the perioperative blood loss, and the characteristics related to the development of the infection, the site and type of infection, the pathogen, the time to diagnosis, the number of debridements, the utilization of VAC, the need for plastic surgery and whether at the end of the day we were able to eradicate the infection successfully. The protocol of management that we use in my institution consisted of prompt surgical debridement and irrigation as necessary, specific antibiotic therapy according to the culture results and the local microbiology guidance from our department, metalwork removal as necessary, and the use of vacuum-assisted devices and plastic surgery for reconstruction as it was necessary. So you can see that out of 858 patients that were operated over the 12-year period, 18 patients developed infection. And that gives us an overall incidence of about 2.1%. The mean age of this cohort was about 38 years. There was a high injury severity score in over 50% of the cases in 10 patients of 27 points. And you can see that the mean duration period of follow-up was 43 months with a range of a minimum of 1 to maximum 12 years. The vast majority of the injuries, according to the Young-Berger's classification, were lateral compression type of injuries and anterior-posterior compression injuries. And 1/5 of them were vertical shear fracture patterns. The vast majority of the patients had associated injuries, as you can see here, and 1/5 rather of the patients had presented with an open pelvic fracture. The mean number of blood units transfused the first 48 hours due to the severity of the pelvic injury and the other associated injuries was 5 units from a range of 0 to 16. The vast majority of these patients, due to the severity of the injuries, were managed with the application of damage control orthopedics. The median time elapsed between injury and definitive surgery was 14 days. 1/5 of them underwent arterial embolization, and the median operative time for definitive surgical procedures was 200 minutes. Now, the mean time from the pelvic reconstruction to the diagnosis of infection was 20 days with a range of 7 to 80 days. The vast majority of them were deep-sided infections, and almost 50% of them were associated with MRSA contamination. And you can see the distribution of the localization of the infections. Pubis symphysis, 35%, sacroiliac joint, 21%, and then combination of the others. And in 1/5 of them, there was also infection around the acetabulum area where we had combined pelvic and acetabulum injuries. Now, as you can see here, that the majority of them were monomicrobial infections, and MRSA was isolated in 70% of the cases, and polymicrobial infections were noted in 7 cases. And in the vast majority of them, we had a combination of coliform bacteria, MRSA, E. coli, and anaerobic species. Of interest, as you can see here, trips to theater for washout and surgical debridement, the median number was 3, and the range was from 1 to 16 trips to theater. VAC closure was utilized in almost 60% of the cases. Metal work removal was necessary in 60% of the cases, and the mean antibiotic therapy, in addition to the surgical debridement, was about 6 weeks. In terms of the outcome of eradication of the infection, all patients were successfully treated but one, who had developed chronic osteomyelitis in his right hemipelvis. So the overall success rate was 93%. As you can see, these patients had a prolonged hospital stay because of this complication, median of 51 days per patient, and a range from 23 to 115 days. ICU support was required in 35% of the cases, and the median ICU stay was 6 days, ranging from 1 to 9 days. So in terms of the overall outcomes, bone union achieved in all but one patient. At the last follow-up, 16 patients were 89%, almost 90% were fully mobile and ambulating without any means of assistance. And complications that we identified in addition to the infection that developed was the development of a Bruker type 4 heterotopic ossification posteriorly, requiring surgical excision, and 2 patients developed pneumonia, which was treated successfully with antibiotic treatment, and there were no deaths recorded in this population. In terms now of the risk factors developing pelvic infection, you can see what has previously reported in the literature: diabetes, open fractures, degloving lesions, excessive bleeding, and the need for transfusion, and these so-called post-traumatic immunoparalysis. But in our patient population, what we identify as the prime parameters, factors contributing to the development of infection, utilizing a logistic regression analysis model, putting together the patients that develop infection, the ones that did not develop infection, we identify independently the following parameters to predict infection: was a high injury severity score, the presence of diabetes, posterior sacral fixation, and excessive alcohol intake. So to summarize, the prevalence of pelvic infection after pelvic reconstruction is low, approximately 2%. The most common pathogen isolated was MRSA. These patients require multiple trips to theater and prolonged antibiotic therapy. If they develop infection, then that results to an increased length of hospital stay and obviously increased cost of treatment. And finally, a multidisciplinary team approach is required in order to optimize the outcomes and minimize the risk of functional impairment. Thank you very much for listening.
Thank you very much, Peter, sir. This was really elaborate, and I wish that nobody gets this kind of infection which you have talked about. If at all we know where to send, if at all there is any infection to that magnitude, should go to Dr. Peter to treat them. Now it's time to have cases, and may I request Dr. KJ Reddy to start with this case, please. Dr. KJ Reddy, sir, are you ready with your case?
Thank you very much, Dr. Shah. Again, that was a wonderful lecture, Peter. It was very appropriate for Indian surgeons, because infection is a dreaded complication, and our infection rate is significantly high, though there is no data, proper data in India. But I think it's very important for us to know these information. So I think we're going to discuss about the case. This is a combination of trauma and orthoplasty. Basically, I'm an orthoplasty surgeon. This is a 28-year-old male treated for fracture dislocation of the acetabulum. As you can see, open reduction was done. 2 weeks later, the hip dislocated, and he presented to me with a painful hip, discharging sinus, unable to weight bear for the last six months. Immediately post-op surgery. So I think I will go through, then we can probably discuss about the case. So what I did was I went in, debrided thoroughly, plate was removed. As you can see, there was resorption of the head, and it was in the dislocated position. The culture grown Staph aureus, his ESR CRP was high, so that was monitored. And I put him on IV antibiotics. So I would like to put them on IV antibiotics minimum of 2 weeks if there is no
Yes, madam.
contraindication. Continue for about
Hello.
6
Yeah, I'm
weeks.
Dr. Dilip Shah. Can you hear me?
Dilip, you
Hello.
have to mute your continue for 6 weeks, maybe longer, based on the clinical condition as well as their I monitor with the ESR, CRP. CRP, as we all know, it's more sensitive. So after 6 weeks, ESR came down from 79 to 9. CRP was negative. I stopped antibiotics, watched him for a month to see whether any recurrence of symptoms, and repeated his ESR CRP. This was at 3 months. He was a visitor. He is from one of the African countries, came for the treatment to me. So this was the hip, because I have CT and all those things I didn't put up. But so at this stage, the hip looked quite safe to do reconstructive procedure. So I went in and I did a total hip, uncemented total hip orthoplasty. You can see the because the acetabulum itself wasn't damaged so much, so it wasn't a big reconstruction. I put a cup in and medialized a little bit more, as you can see, and had a stable hip. So we had about 1 year follow-up over the phone. So there was no recurrence of infection, pain-free. He was able to walk well. After 1 year, no contact. Patient did not contact me. I was telling the other day, probably he was doing well. The second reason could be he might have had some problem, went in to see some other surgeon. But hopefully, I'm sure he's doing well. That was the case. I think probably would like to take any questions or any comments, or anyone would have done in a different way.
Certainly. May I request all the participants in this group to unmute themselves, and you can keep your video on and ask the question by raising your hand.
I'm raising my hand.
Yeah, please, Kevin, go ahead, sir.
I think that's very nice, and yeah, it's not, you know, I know Peter reported 2.1%. At our hospital, I think it's closer to 5%, and but we do get referrals like this as well. I just did this exact case yesterday, but we treat it as if it's an infected total joint, and so I do 2-stage conversion to arthroplasty. So I would always we convert septic native joints to we treat them like it's an infected total joint and just convert them. So we put in an articulated spacer with a cemented poly cup with extra antibiotic cement, put in an undersized cemented stem again, and then an articulated spacer, and then we wait as long as 18 months before we go back and convert them over.
So what would be your interval, Dr. Kevin? What would be interval between stage 1? How long would you like to wait, or what would be the minimum interval?
Yeah, normally we would wait at least 6 months, depending on the age of the patient, things. But I've waited as long as 11 years, and I've had patients go 8-9 years and then get converted. Some you can do.
And how long would you give the antibiotics?
We would cover them with 3 months of antibiotics, 12 weeks.
And how much IV and how much oral antibiotics, if it's appropriate?
Yeah, normally, roughly 6 weeks of IV antibiotics, and then they continue and get covered for a total of 12 weeks, if possible.
Up to 12 weeks, yeah.
In your spacer, Kevin, you put antibiotics as well?
Yes, antibiotic cement. So we use undersized, a polished tapered stem for the stem, and you set it up so that you know that you're coming back. So I don't put any cement past the tip of the stem, and then also we undersize the cup a little bit. So yesterday I think I reamed to 54 and I put in a 50 cup, so it had an extra mantle of antibiotic cement. Yeah.
So you've got a bit of local delivery as well. My question is, for the case, did you actually do a biopsy before you went back to do the hip, or did you just base your decision on the state of the soft tissues and the biochemical?
Yes, I did not do any aspiration. No, I think there was no suspicion clinically. There was no evidence of any infection, and his ESR CRP was quite normal. I didn't do any aspiration of the hip or biopsy of the hip.
Yeah, it's just that the whole cartilage of the socket disappeared, and that was a concern to me, whether there was anything left behind. That's why I asked you.
Oh, this one you mean to say?
No, that's from the fracture, isn't it?
Yes, that's a posterior wall. That was the reason. I mean, they tried to fix it, but I think it wasn't a proper one, so got dislocated.
Yeah. Okay.
I have a question, Dr. Reddy. What antibiotic, since when you are redone the surgery, there is already it's a sterile. So which antibiotic you will continue IV, as well as which antibiotic you will continue oral for how much duration?
Yeah, that's a very good question. Because most of the people do ask. See, when we go in, we take it as a clean case. My prophylactic antibiotics will be like doing a primary joint. So it won't be different. I would not prolong my antibiotics. It would be the same like doing a primary joint. Excellent question. I think most of the people are quite concerned. They would like to continue antibiotics maybe longer. There is no evidence to say it will help the patient. So it would be like a primary joint when you do the second stage. I would like to take inputs from Dr. Tetsworth as well as Dr. Peter Jonas about antibiotic policy for a second stage. How long would you give and what?
Look, this is always something that we debate within the team and the microbiologists, and always depending on what was the original pathogen and whether it was resistant, what kind of combination we need to give to get good penetration and so on. So the first hit is the most important one to create the so-called aseptic environment. During the second stage, of course, we're going to take cultures again. If they come back negative, we don't give. After 3-4 days, we stop them.
Yeah, I think that's why I think did you ask the question? I'll always do second stage. If any suspicion, I send it for microscopy, and against cultures, we send for cultures, but not preoperatively. Intraoperatively, send the tissues for cultures routinely for all cases where we do second stage infection. Yes, Kevin, that's what. Yeah.
All our revision total hips, we do 12. We cover them for 12 weeks regardless, and that comes out of the papers by the groups in Chicago and Craig Del Valle, and it was the K. Wilkins Award winner in 2007 and again in 2018, I believe, where they looked and did a randomized controlled trial. Relatively small numbers, only about 180 patients, I think, but they gave an extended spectrum antibiotic coverage, even in the ones that were culture negative, and they had a better outcome. So we have adopted that practice, and we would routinely cover with oral antibiotics for about 12 weeks.
How many? So second stage, you prolong antibiotics for how long?
12 weeks.
12 weeks.
12 weeks. Okay, I think that's probably something new, but I think practice, most of the orthoplasty surgeons for a second stage, we strongly believe there is no evidence to say that it will reduce the incidence of infection if you prolong antibiotics. Of course, that's your practice.
So you want to keep standard of 6 weeks intravenous and then get all the parameters.
Yeah, that's how your first stage. For the second stage is prophylactic antibiotics, like 1 dose pre-op, 3 doses post-op.
That's very nice. Should we go ahead with second case? And all this discussion we can have after the cases also are presented. Is it okay to you, Reddy sir?
Yeah, sure. I have a probable case.
So, allow me to share the screen.
So you can.
Thank you so much.
Thank you.
I want to present a case which is quite unique for our situations. I don't know how many of you abroad also will be seeing them. This is a case of 62 years old lady who had hemiarthroplasty of the left hip for a transcervical fracture 4 years ago. For the last 2 months, when she reported to me, there was increasing pain and discomfort, and she had many other complications which we solved before the surgery. But this was the picture with which she came to me. A 62 years old lady, 4 years ago, she was operated. Even at the surgical time also, there were 2 cerclages cemented as exuded out from this situation. She is unable to walk. This is the picture. And this is the scanogram. So the diagnosis of fractured cemented bipolar prosthesis implanted of the left hip was done. So what would you like to do for this? May I have the opinion? Everybody can be unmuted and can participate. Or I'll go ahead.
Yeah, probably if you stop and ask people which I should have done it, would be more interesting. Probably can ask.
But I'm doing it. So you participate now. What will you do?
Yes, you have to remove that. Yes.
We will ask someone else to answer.
Yeah, as an Indian experience, let me tell you, you have to remove it and insert a new processes. It's as simple as that. How to do that?
It is not that simple, because the proximal area also, you see what is the situation. Okay.
Yes.
So,
Can you put the X-ray back, Dr. Shah?
certainly I'll do that. This is it.
Yeah, I think, see, you can't leave it like that. You have to take the implant out, cement out, and put a new implant in. Probably, I would do a window at the bottom, because you can't see much of the cement at the bottom, and put it wide at the top. So you may be able to extract everything out, but you have to extend it.
Okay. So I will go ahead with what I did.
Is the sedimentation rate elevated above 93?
Couldn't hear.
Is the sedimentation rate elevated? Or any other
Elevated.
parameters?
No. There was no infection as such, and ESR CRP was normal. No infection. So during surgery, the proximal part of the prosthesis came out with removal of the cement, and further hammering of the prosthesis was done to break the bondage. The ETO, which we normally do up to the greater trochanter, was not done. It was stopped short just below the second cerclage, and I had made a muscle flap also in that ETO, and bone quality was bad at the level of bone plug. So distal to the bone plug, 2 centimeters distal to that, I made 15 millimeters rimming on guide wire on both the sides. A Wagner 16 millimeter prosthesis was introduced, and a 41 millimeter bipolar prosthesis would presumably, it will allow less chances of dislocation. But to my surprise and everybody's surprise, it was in 3 parts. And this is a cement which I could take out. So this was in 3 parts. But interesting part is, finally the subtrochanteric osteotomy was cerclaged. Allografts were put in the appropriate places, and prophylactic antibiotic cement beads of stimulant were put. I want to address at this situation that I normally put 2 cerclages distal to the area where the prosthesis will go to prevent the further fracture. But there was no name of the manufacturer also on this prosthesis. So this is the result at the end of it. And this is at the end of 1 year. It's open. It's open. You don't have to appreciate. You can be critical.
Yeah, I think I would just one comment, Dr. Shah. Probably, if we feel it's not infected, you don't have to take entire cement out. If you can get the implant out and well-fixed cement, you can do cement in technique. And
agreed. Agreed. But what happens is, when you have this kind of hollow in the bone, cement in cement, there'll be too much of cement, and I would prefer an uncemented prosthesis. And that's being a surgery where I suspected there may be infection, so there was a reason to use stimulant. But stimulant, those who have experienced, what do you feel? There may be serous discharge for 6 weeks post-surgery. Anybody has found this?
Yes, we've observed the same thing. Serious discharge, very common.
You get scared, really. It comes almost in liters, you can really say, then whether to put stimulant or not.
And what do you do when you see the discharge, which presumably is aseptic, discharge? Do you cover them on antibiotics?
No, antibiotics were discontinued, and whatever was the serious discharge was very meticulously collected and sent for smear culture, and there was no growth. So I didn't want to add antibiotics.
The similar phenomenon was observed when we were using the BMPs a bit superficially, like in the clavicle, in the tibia. You would get this aseptic kind of a discharge of a hemoserous fluid for a period of time. And what I learned from that was that unless you cover them, then they become infected, because it can run for 2 weeks, 3 weeks. So in my practice, whenever I have something like that, I put them prophylactically on antibiotics until the sinus stops discharging.
That's a nice idea. Very good. And you would continue with intravenous.
Okay.
Okay. Can we request Kevin, sir? Can you go ahead with your case? I'll stop sharing my screen, sir.
I want to ask Dr. KJ Reddy, since he has got a large experience of this doing revision surgeries. How common is this double fractures in a prosthesis system? Because I feel that the load has to be transmitted at one point and not at 2 points where it can break. How it can break?
That's very unusual. I mean, I haven't come across prosthesis breaking in 2 points, because what happens most of the time, the distal part is well fixed, the proximal part is not well fixed. So there is a stress concentration at that juncture. So most of the time it's a breakage at that level, but that's also, I've never seen breaking into 2 pieces, unless, I'm sure, I trust you, Dr. Shah, you haven't broken while you're taking it out.
No. Because immediately we were watching on the C-arm, and at that time I saw there are 3 pieces, although the last X-ray also didn't show.
Yeah. I'm sure that would be, but sometimes it can happen, but that's very unusual, Dr. Shivashankar. I think generally it is one fracture at the junction of...
That's what the idea of presenting is. How many people have seen it into 3 parts?
Yeah, probably the quality of the implant, as you rightly said, there was no name.
There was no name on that.
Yeah, that can tell that it's a substandard implant. So let's blame on the metal here.
So we don't blame any instrument manufacturer also.
Yeah.
Kevin, sir, your case, sir.
Yes.
Okay, Yep. All right. Well, I'm going to share a case here that's neglected trauma, and I know that in India you certainly deal with a lot of neglected trauma. We have some in Australia too, particularly in Queensland. It's a very big state, and sometimes patients need to travel long distances. So this is a woman who was thrown from the vehicle and sustained a closed head injury. And I think the people in the ICU thought she was going to die, but she had a closed head injury, multiple other injuries, and this bad injury of her tibia, 3B, open segmental tibia fracture, 8 centimeters of bone loss, and this more proximal fracture. And because of her closed head injury, they thought she was going to die. So they didn't get us much involved, and we thought she had died. And then 5 weeks later, it turned out, well, no, she was still alive, but they had neglected this wound. Unfortunately, we see this from time to time. And now we have a problem because she has necrotic bone and necrotic tendons and a segmental defect, 8 centimeters of bone loss. And so the question becomes, how can you manage this and what are your options? And whether we're going to do an amputation or try limb salvage. And at that time, she was waking up and she wasn't, she was keen to try and do some sort of limb salvage. So we asked plastic surgery, what could they offer and could they cover this? And they felt like they were busy this month. They felt just amputate. We have a very hands-off approach from many of our plastic surgeons. And so it's a bit of an issue for us from time to time where you'll get this attitude. They say, yeah, it's easier just to amputate this thing. So the question becomes now, how do you approach this problem and what sort of options do you have, if any, to reconstruct this without plastic surgery. So I'll ask the question now. Anybody have any opinions or suggestions as to how they might approach the problem? It's a difficult one. It's not easy.
Yeah. You can debride it thoroughly, then add wax also. And also now you can stretch the skin by putting balloons wherever it is possible and stretch the skin. Then you can do the bone transportation with Elizero. So these are all the options you have got, but it is a long procedure. It will take at least about 1.5 to 2 years. That has to be explained ahead if you are using a bone transport with Elizero system.
Yeah, up to, we would usually recommend or usually advise, and it takes up to a year to finish some sort of salvage that way. Well, we did exactly that, and after we'd done the debridement, we've applied the fixator, and I will apply the fixator such that I ignore the distal end. So I put the frame on so it's anatomically aligned with the proximal end, which is intact, reduce that original more proximal fracture that wasn't really badly displaced. And now this next picture just shows you that really what you're doing is you position the foot in space relative to the proximal segment. So I put the frame on so that it lines up with the proximal segment, and then I can position the foot anywhere in space so that it matches up with where the transport is going to end up. But here we debrided, and now we had these muscles that the tendon was dead, the muscles weren't attached to anything, so I could take them and move them around and put them pretty much wherever I wanted to get the coverage I needed. And so we did enough of a shortening that actually now we had this extra bit of muscle that we could just move around where we wanted, cover the wound. And instead of putting a free flap on, she got these local muscles. She was shortened a bit. And there she is. And we used that original minimally displaced fracture, the more proximal fracture. By this point, it was already gotten out to about 8 weeks. We just let it sit there for a few more weeks. And then we started to gradually distract and do a true calotasis, so distracting through the fracture callus. So initially we swung things around. We later, that's after the skin graft has matured. We just put skin grafts right on top. So initially vac dressing on top of these exposed muscles, and then converted to a skin graft. And so she got a bit of acute shortening combined with some transport and then lengthening later on. And we distracted through that original fracture, and it formed reasonable bone, not great bone, but it formed pretty good bone as a true calotasis. And I will tell you, this one, she was very remote from us. She was about 350 kilometers away. She was reluctant to come back. She was reasonably non-compliant in terms of her follow-up. And so I say that, it was difficult for her. It was difficult for us to manage her. And I will say she is one of my worst clinical outcomes in that she continued to transport and went right into her ankle. So originally her ankle was intact and a pretty good ankle, but she just transported straight into it and displaced it and caused other problems for it. So it made it a bit more of a challenge. But here she was, and it took her right around almost 10 months to complete her treatment. So not quite a year, but almost 10 months. That's very early on after. But she did grow bone. She did solidify the bone, and it did come down and heal on the far end at the docking site. But in fact, displaced a bit through the ankle and things, wasn't as nice as it might have been. And so this is here. And then 2 years afterwards, and I've since recently seen her more recently, and we did put a nail down there eventually because we were worried that the bone was so weak and wasn't going to tolerate things. But in fact, she's done reasonably well, and I continue to see her, and she's probably 16, 17 years down the line now, and has a bit of a flexion contracture of her knee, but seems to work out well enough for her. She seems to be happy with it. So a tough case, but to show you the possibilities of what you can do when all hope is lost and you have nothing else you can do or offer. You sometimes try things that seem unlikely to work, and sometimes you get lucky.
That was excellent. And what was the? I know it is very difficult. What was the function of the foot like?
Function, yeah.
Yeah, functional. I mean, she walks on it. As I say, her biggest limitation is actually her knee flexion contracture. She has about a 15-degree knee flexion contraction, but she walks on a full weight band. She works on a property, on a farmyard, and and has very little pain and walks without any special shoe or modified shoe or anything, or brace, or she just walks around. So she's done quite well, really.
It's an excellent job. Actually, you have given life to the limb and a better life to this person who had suffered from this injury. We had a good discussion, and the panel discussion of this part also, we'll have it at the end of it for actually appreciating the time factor. And may I request Dr. Peter to go ahead with his talk on muscular technique.
By the time Peter is sharing his screen, I'll ask this, Kevin, what different you would have done today if the same patient comes? I know this you have done 17, 18 years back. Would you have used a self-lengthening interlocking nail or something like that?
Yes, now we've gone to using totally contained devices and magnetically controlled precise nail, or even doing a transport nail. We've developed some that contain a standard precise nail, but here just a regular transport nail may not have worked because the distal fragment was so small, so we would have had to do something a little bit special, but maybe even a plate-assisted bone transport.
Okay, thank you.
So I guess we can go to the next talk of the session, the role of the muscular technique in the treatment of infected non-unions. So first of all, I would like to talk to you about the problem. And the problem we are talking about is the presence of non-union, but also the presence of infection at the same time. And if we think that we're going to have to debride the infected, the dead bone, then we are left with a bone defect that is created. And this is the challenge that we need to treat with this technique. Everyone should be familiar with these basic principles of management of infected non-union. You need to make sure that you have not lost any kind of important information. So you need to take a full history. You need to talk to the patient. You need to listen to the patient. You need to examine the patient thoroughly. You need to evaluate any leg length discrepancy, any rotational deformity, malalignments. You need to proceed with the other investigations which will complement your clinical assessment, radiographs, blood tests, CT scans, PAS swab, MRI, whatever you think will be most appropriate to get the information that you need so that you can dictate the treatment plan, the treatment strategy, how to manage this difficult situation. The overall objective is to convert a septic to an aseptic environment. And then these may well be one or several stages to get to these asepsis. You need to provide adequate stabilization to the extremity. And then at a later stage, you need to think about how you can regenerate the bone, how you can promote a successful osteogenesis, a bone healing response. So let me describe you now quickly the muscular technique. This is Allen who first reported the technique, how we use it nowadays to be able to deal with bone defects. That was, you can see here his original publication in the French language, year 2000, and then the same publication, exactly the same, was published in an English-spoken journal. But because of the importance, no one ever questioned whether this is a duplicate publication in terms of the academic kind of ethical aspects. So in his first publication, he reported 35 cases of bone reconstruction, where he said that it was possible for the patients to restore their function at about 8.5 months on average. And the length of reconstructed defect was from 4 to 25 centimeters. And this is when the journey started. Now, if we look to the technique itself, very, very quickly, first of all, this is a tibial infected non-union case. So you need to think about the soft tissue debridement, as you can see here, bone debridement. You can see inside the broken metal work the nail. And when you debride thoroughly the bone and you've got clear margins, you must be sure that whatever you left behind is a very vascular bed. So your debridement, as it was highlighted previously, must be to the highest standard. You need to send multiple tissue samples to microbiology for culture. And then step 3, you need to implant a cement spacer where the defect was created. In my practice, I always add antibiotics to the cement spacer, usually vancomycin. And then you need to think about how you will stabilize temporarily the affected extremity. You can use an external fixator, as you can see here, or a circular frame, whatever you think will be most appropriate for that specific patient, that specific case. And then you need to proceed with definitive soft tissue reconstruction. If you can do it primarily in one stage, that's great. If not, then you need to think about a rotational flap or a free tissue transfer to be able to reconstruct the surrounding soft tissue envelope. You need to consider then thromboprophylaxis, antibiotics for a period of 6 weeks. This is what normally we do in my unit. You must have a protocol for pin-side care, and you must optimize any underlying patient comorbidities in relation to his medication, in relation to his bone metabolism. For instance, vitamin D, you need to check his thyroid function, etc. Step 6 is you need to return back to theater on average between 6 to 8 weeks after the first stage. And before you do that, you need to consider what type of bone graft you want to implant. Any adjuncts for biological stimulation, for instance, a growth factor, or to create a more abundant cellular environment by implanting bone marrow aspirates. And you need to think about what will be the implant you want to use for the definitive stabilization of the defect, the affected extremity. As you can see here, I use a lot the rear device because I can get as much bone graft as I need. I don't go to the pelvis anymore. And when you do that and you harvest your graft, then step 8, you need to expose the membrane. You can see here how well the membrane is formed. So you need to protect it. You need to remove the cement spacer. Then you need to calculate the length of the defect. It is always routine in my practice. When I go back for the second stage, I always debride more the bone to reach to some fresh vital edges, and also to send some of this bone for culture. It's my routine practice, and if I make the bone defect longer, it doesn't really matter because the technique works well. And then you need, on this case, as you can see, I used the plates. That was the definitive option for implant for the stabilization. You can see here the rear graft that was implanted. And then you proceed with closure of the membrane, as you can see here. When the membrane is well formed, you can even cover the implant with the membrane. And like that, you can create a true local bioreactor where you want to see all this intense activity for bone regeneration. You need again to think from thromboprophylaxis, plan the rehabilitation, and arrange the follow-up visits in your clinic. And you can see in this case the post-operative pictures, how from gradually over a period of 3 months, you can see some mineralization of the graft material. And over a period of 7 months, you can see the restoration of healing, the osteointegration of the graft, the anatomical bridging of the previous bone defect, and even the formation of the medullary cavity. Now, in terms of the results of treatment, we published our series from Leeds a few years back. We reported 43 patients. Half of them had an infected non-union. They ended up having a bone defect due to the debridement. The overall mean length of the bone defect area was 4.2 centimeters. The range was from 2 to 12 centimeters. And as you can see, that the mean time to radiological union was 5.4 months, range 2 to 12 months. And the mean time of healing of 1 centimeter bone defect was 1.24 months. So our overall success rate was 98%. We have published with the father of the technique, Alan, in the American volume of JBJS about the technique, all the tips and tricks, how it should be done properly to optimize the success of treatment. So to summarize, the induced membrane or muscular technique is a very good option to consider for the treatment of infected non-union with bone defects. Defects up to 25 centimeters can be treated successfully. And if you perform the technique well, if you follow the principles, if you manage to convert the septic to the aseptic to an aseptic environment, then your technique will be optimum, will be very successful. If you leave dead bone behind, if you leave residual infection behind, obviously the technique is not going to work like any other technique. And then you need to go back to step one to start again from the beginning to reapply the technique. And I'm saying that because if you remember, we had a series from Wales where they criticized the technique, but in their results, 50% of their failures had ongoing underlying infection. It was a small case series, 14 patients. So if you fail to do a good debridement, if you fail to develop an aseptic environment, is not the technique, is the surgery you do. And with that in mind, I would like to finish my talk and to thank you for your attention.
Thank you very much, Peter. That was a wonderful talk. And we will have some discussion at the end. Now, can I invite my good friend, Dr. Shivashankar, our president of Indian Orthopaedic Association and great teacher, excellent surgeon, is a special interest in trauma, is going to talk on exchange nailing in non-union of proximal femur. Dr. Shivashankar.
Thank you very much, sir. In this infection, I don't know why I was given this exchange nailing only. I might probably to change the subject probably. Anyway, it's a better change. Friends, for a non-union, if the fixation is substandard, you have to give mechanical support. If biology is not good, you have to give biological support. If both of them are questionable, then you have to give biomechanical stability. This is all the theory I speak, but let me show some cases. This was a young guy, a medical intern. Open nailing was done with a thinner nail. Then bone grafting was also done subsequently. When he came to me at 14 months, there was broken nail as well as non-union. So we thought we'll only exchange with a thicker nail with a ream product to work as graft. So I just did a closed exchange nailing after removal of the broken pieces. This is way back 15, 16 years back. So I only exchanged the nail with a thicker nail, did not do any grafting. This person living almost 500 kilometers away sent me the pictures after 7 months, which showed that luckily this internal grafting had worked. And this is when I clinically saw him at 9 years post-surgery when everything had consolidated. Another case during the similar time, again 14 months old, non-union with a broken nail, similar fracture, came to me. Since I was happy with the earlier case, I did the similar technique of exchange nailing with a thicker nail. This is in 2004. Then after 14 months, still you can see that the fracture is not consolidated that well. In the hindsight, I think I should have hastened the union by bone grafting, since earlier open nailing was done. Probably the ends also probably were the problematic. This is in 2010. After 6 years, the fracture appeared consolidated. I removed the implant. And after 2.5 years, in 2013, with a trivial trauma, he had a refracture. This time, I didn't want to take any risk. I opened the fracture, freshened the both, and still I could see the punctate bleeding, tingling, bone grafting, multi-lock, well-fitting nail was inserted. This is all I did. Within 4 months, you can see beautiful consolidation. The stability was given by multi-locking proximally, multi-locking distally also, then shingling, bone grafting added to the biology also. Probably if the patient comes to me today, I will do a local augmentation plate. The reason is nail for a non-union is not a good option with locking away. It is only good for isthmial fracture, but not at junctional fractures. So I might add a augmentation plate. So the topic I have taken is non-union, which requires absolute stability, which can be given only by plating with compression. If you are a nailer like me, then you can augment the nail with an augmentation plate to give stability, what the fracture is begging for. Nail gives stability over longer whole length of the bone, and plate decreases the working length at the fracture site. This is an example to show the technique. A fracture femur, nailing done, went into non-union, treated with a thicker nail and a plate augmentation plate, a spring plate or a wave plate, so that one can do bone grafting 360-degree all around. So this is at 6 months, you can see nice consolidation, function at 6 months. Then this is at 4.5 years when the patient came for implant removal. This is at 4.5 years, I have removed the implant. There was no infection or anything. I normally tend to remove all the implants. This is an interesting case. This patient was treated 10 years back by proximal femoral nail when this sustained fracture of the nail and he was unable to walk. If you see the entry, you can see that the entry has been taken from the tip of the trochanter leading to varus of the proximal fragment. That was the reason why the fracture was not uniting. Then when I took the patient for surgery, I inserted Steinmann pin at lateral to the entry side there, and they made a fresh entry from the piriformis fossa, that is the center of the neck. This Steinmann pin prevented my reamer going back to the earlier track. I also inserted an anti-version guide wire to see the direction of the neck. I did a proximal femoral nail with an augmentation plate at bone grafting. This is immediate postoperative picture. These are the immediate postoperative pictures which shows the plate and the nail. And you can see at around 6 months time, beautifully it had consolidated. This polar screw is to prevent the nail going back to the original track, which was much more lateral. So this is the function of the same patient when he had come for one of the follow-ups. Another case, femur nailing was done. Again, the entry from the tip had led to the varus of the proximal fragment. In due course of time, the nail broke, fracture went into non-union. The surgeon just removed the broken proximal piece. That was the time I came to picture. I could, by close technique, extract the broken nail. As the patient had not walked for almost 1 to 1.5 years, when I started doing the nailing, I iatrogenically caused lateral wall fracture. So I had to do the wiring in this patient, then did the PFN and augmentation plate and bone grafting. This is in 2018 when I had done the surgery. This is after 2 years showing nice consolidation. There was a discharging sinus. The patient was diabetic and I had to remove the implant. At that time, I have used antibiotic coated beads and she's doing subsequently well. This young boy was treated with plate for a fractured femur in childhood. He came with a fresh trauma and fracture in the subtrochanteric region. The surgeon decided to remove the implants and put a locking plate. He was unable to remove all the broken screws here in the distal fragment. And unfortunately, that didn't work well. And the patient came with a broken implant. This was the time proximal femoral nail with augmentation plate and bone graft technique was used after retrieving all the broken screws. You can see the nail is splinting the whole length of the femur where the broken screws were extracted using the hollow mill. So this is the follow-up X-ray. After 1 year, you can see beautiful consolidation of the fracture and the function when it had come during lockdown for the follow-up. Another case, subtrochanteric fracture with a non-union. Again, in this case, I have inserted the K-wire as an anti-version guide wire first because I have done this surgery in the lateral position. As the neck screws were well positioned, parallelly I have passed a K-wire as an anti-version guide wire for subsequent knowing. This is at the end of the surgery. If you are thinking how we can drill in screw by the side of the nail, it's always better to use a K-wire first, and it can hit the nail, then you can slip beside the nail and gradually you can enlarge that hole. If you directly use the drill bit, many a time it breaks. So using the K-wire is the crux of the treatment. This is the follow-up X-rays, and this is the latest X-ray showing good consolidation in that fracture. This is a recently done case. This patient was operated about 7-8 years back for fractured femur, and he suddenly started getting pain in January this year. The X-ray showed that the subtrochanteric fracture had not united and the nail also had broken. He came to surgery after 2 months in March. When we took the X-ray, the AP X-ray showed that it appeared united. I was a little confused. I thought whether the auto-dynamization of breaking of nail has helped in union of the fracture. At the end of 8 years, when I got a lateral picture done, you can see that there was a definitive non-union, and this was just the picture. AP picture was just a defective picture. Again, in this case, I removed the proximal broken piece of the nail, which came out very easily, and removed the distal broken piece within the nail by inserting the broken nail extractor. Incidentally, I was involved in the designing of this broken nail extractor, and then I could extract this broken piece. Here, after inserting the extractor into the nail, I am removing the distal locking, and then I'm trying to taking out the nail. As the nail was very loose, it came out very easily. Then again, in this case also, I did proximal femoral nail with additional augmentation plate, as you can see in this picture. So this is the broken implants I have extracted. You can see that the extractor could cut a thread within the nail. This is the immediate postoperative picture, though it looks united. Friends, it's just an immediate postoperative picture, which due to good alignment and beautiful grafting, it appears in that fashion. And yet to see any other follow-up in this patient. Another case, a borrowed slide from my friend, Dr. Rajendra Chandak, a subtrochanteric fracture treated with a plate, which gave way in due course of time, treated by the surgeon with a nail. Unfortunately, that also went into non-union. That was the time Dr. Chandak took over the case, and he did augmentation plate with a plate as well as a fibula graft. He has used fibula graft also and fixed with two screws, and this also case went on to unite without any problem. So this augmentation really works, especially in non-union cases. This is the last case I am showing. Multiple surgeries done in this patient. Almost 8 surgeries have happened, and in spite of that, the fracture had not united. This is in 2015, the last surgery when the plating was done. In 2018, the patient came with a broken plate. That time, I used again the femur nail with double augmentation plate. Anteriorly also I had augmented, and laterally also, as the bone was soft, I augmented with the plate. This is immediate postoperative picture at 6 months showing good consolidation, and later on at 18 months, you can see beautifully the fracture has consolidated. Friends, aseptic non-union, if it is hypertrophic, if that is due to insufficient stability, increase the stability by surgery. Refixation with proper nail or ream thicker nail is sufficient. If it is due to atrophic non-union, if stability is good, just add bone grafting, that will take care. If stability is not good, then stable fixation and bone grafting with nail and augmentation plate, as I have shown in these cases, or you can also do plating. To conclude, in established non-union, shorter working length by using thicker nail and local augmentation plate, removal of avascular bones, augment the biology with local bone graft if you are opening the fracture for any reason. Compression plating also works very well in this junctional area, but my topic was nail with augmentation plate. Thank you very much.
Dr. Shiva, you have done wonderful justice, and we only want to test your methodology, how you could make everything so interesting. Really, it was very nice. And may I request Dr. Ritab from Delhi to take over and start his presentation. Dr. Ritab?
Is it Dr. Kevin?
Oh, sorry, it's my mistake. But Dr. Kevin Tetsworth. Yeah. Contemporary treatment. Dr. Kevin, I'm extremely sorry. I jumped. Contemporary treatment of infected tibial non-unions. Dr. Kevin, can you please go ahead?
Sure, I'm happy to. Yeah. And again, come to you from Brisbane and Sydney. And I'm in Brisbane tonight. It's late at night, 1 a.m, but things are going strong here. And I think all of you would know what to do with this case, infected non-union of the tibia. This needs the hardware removed, need to manage the soft tissue, need to give appropriate antibiotics. So it's to this step, we all would agree. Hardware comes out, dead bone needs to be removed, and then how do you sort it out from there? And again, the disclosures, none of which applies. So these principles of treatment, this is the 2-stage treatment. I was George Cerny's fellow, and he was trained as an orthopedic oncologist under Bill Enneking in Florida. So he was trained in tumor surgery. And Enneking went on vacation at some point during his fellowship and told George to take care of a bunch of infected cases. And George's solution was to apply the same principles to the infections that he had been using for the tumors that he'd been learning under Bill Enneking. So that's where the 2-stage protocol came from. But these principles are established. And this article that I wrote together with George before he unfortunately died a few years ago, this came from the time I was his fellow. And I wrote down everything that he said. It was like the words coming down from God. And I wrote it down in this little notebook. And 8 or 9 years later, I put it all together and we published a paper on it. But it outlines these principles. 2-stage management, getting source control, meaning good debridement, which we've talked about, the importance of that, removing all foreign material and devitalized tissue, but preserving local vascularity. And then the role of stability, as you just heard the last speaker, emphasizing the role of stability. This applies also for managing infection. And so whether that takes the form of external fixation or IM nails, often antibiotic coated, or antibiotic plates even. Now we've gone to making some antibiotic plates. And I meant to include a case, sorry I didn't, but you can make locked plates. And if you put the towers into it ahead of time where you plan to put screws, then you can put a little coating, maybe 3 or 4 millimeters thick of antibiotic methacrylate on there, let it go off, then take the towers off, is a nice way to make an antibiotic plate. So local antibiotic spacers play a really big role. And when you manage chronic infections, you get to be very good at making different types of spacers. Getting the plastic surgeons involved, soft tissue coverage important, giving pathogen-specific antibiotics, and then delaying the return to do your definitive bony reconstruction until you have the infection under control. And although we didn't say in that paper that it was analogous with tumor surgery, Hamish Simpson then later on did make this direct analogy with tumor surgery and noted that the biopsies are extremely important, that the antibiotics are the same as giving adjuvant chemotherapy in the tumor world. It's the same sort of principle, but you need adequate margins. And Hamish showed that 5 millimeter margin is adequate for a chronic infection. If you have 5 millimeters of normal tissue, that's enough. And I will say that the inexperienced surgeons, I often see them resect exuberantly. And we had somebody here locally across town from me and resected 34 centimeters of tibia for a chronic infection. That was excessive. It did not need a 34 centimeter resection. I think a 10 centimeter resection would have been too much. So they definitely got a good margin. I have to give them that. But my advice is that if you have an infected union, it is almost never the right thing to do is to make a segmental defect. You should be able to reconstruct it. If it's intact bone, it should be able to be reconstructed. And Peter already showed you earlier the role of an antibiotic nail, and we do a lot of antibiotic nails. I think delivering local antibiotics is really critical, especially if you've reamed out an IM canal. And Rhinelander showed this, and Truetta showed this, in the 1970s, and even back into the mid-50s, demonstrated in animal studies that if you ream the canal of a bone, it destroys that blood supply, intramedullary blood supply. The endosteum becomes avascular for a period of 6 weeks or more. And so if you get systemic antibiotics in that early postoperative period, after you've reamed the tibia, the antibiotic is going everywhere in the body except for where it's needed. And this is why I think so often treatment fails with IM nail and doing a simple exchange of things. So we've moved away largely from making these antibiotic nails, making a nail like this and coating it with methacrylate, as you see in the left-hand picture there, because it often flakes off, and you have to use an undersized nail and make a very thick mantle on it, or it flakes off. And we've also moved away from using K-wires or Steinman pins and things. I think using Ilizarov threaded rods is a very, very good approach to use. And so we have a little kit that's set up to use Ilizarov threaded rods. Here, this is some old x-rays of mine. This is another way you can do it with bending over Steinman pins and things like that. The antibiotics that we use for a nail, normally I use Simplex. I did a paper with John Mader that showed that antibiotics elute much better from Palicos, but because now we will often squirt it down a chest tube, and the center picture you see there, that nice smooth cement mallee you have, it makes it very easy to remove. It's so slick, and the contour is perfectly smooth if you inject it into a tube like a chest tube. And to do that, you need to use Simplex. And that same paper that I worked with John Mader, we showed that if you give 1 gram of antibiotic, 1 gram of vancomycin into methacrylate, it elutes above the MBC, the minimum bactericidal concentration, for about 2 days. And if you put 2 grams of antibiotic, it elutes for 10 days. And if you put 3 grams of vancomycin in there, it elutes for over 60 days. We stopped after 60 days because it was going on asymptotically. It looked like it was just going to go on for a long time at a very good level. So adding 3 grams of vancomycin is really what you need to do. And that's just the simple facts of how it elutes from the methacrylate. And we add the Fluclox. Now I know there's a lot of you that are saying, that the Fluclox is not heat stable. And it's probably not. We don't really know. It's not heat stable. The penicillins are not heat stable. But when they make commercial antibiotic cements, they add gelatin to it to help the antibiotic elute. And I know for a fact that the gelatin has no antibiotic properties, whereas the Fluclox will serve the same purpose as the gelatin, but if it retains some of its antibiotic activity, that's good. So I put Fluclox in as well. That's just why we do it. Now I do a bit of outreach. I go to Baghdad periodically. We go into what was previously a war zone, and we're restricted there now. We're unable to go back at this time because of the change in the political situation and things. But I've been there many times, 5-6 times at least. We do a lot of surgery when we're there. And so we sometimes work under relatively austere conditions. And so this is just making a hand-rolled nail without a chest tube. They didn't have a chest tube available for us, so we just rolled it out. And I took the opportunity to make a video of one of my friends having a bit of fun making the nail. But that was for an infection that ended up with an amputation as well at the same time, preparing it to do osseointegration, which I will talk to you about. I think it's tomorrow morning. I'll go through one case, and this is, again, a neglected trauma case. As I noted, in Queensland, we often get these neglected trauma cases. This was somebody who sustained high-energy trauma, cyclist, a bicyclist, a pedal bicyclist, not a motorcyclist, struck by a big tractor trailer going 100 kilometers an hour. So had head injury, and again was in distress, and this was at 5 days. Somebody on the team fixed this, and at that time we didn't have anybody else capable of doing lots of the pelvic fixation, and I happened to be overseas giving some lectures and things. And when I returned on the 24th day, we did this reduction and put some iliosacral screws, and it's not a perfect reduction, but it's certainly stabilized it and gone on to heal. But in the meantime, he also had sustained this open tibia fracture, which somebody had taken a very low quality picture of, but it was a pretty benign injury, really. It's not a terrible open fracture and not a bad fracture, not even a badly displaced fracture. It's in this external fixture. And then by day 24, when it's been ignored, I know that I don't want to sound like a broken record, but we see this periodically where you have wounds where they expect the patient to die, they've neglected the wounds, it's developed some deep infection, a bad infection. I think it's an enterococcus infection, as I recall, infected with Enterobacter cloacae, and that's at 24 days, which is what greets me when I return from coming overseas, is this displaced posterior pelvis, as well as this now a bad open proximal tibia fracture. So the original injury, not so bad, and could have been managed quite easily. And if the wound had been managed appropriately, probably didn't even need a flap, but now we do. So now I have the situation that I'll call an infected non-union of a tibia. And so the principles are resect the dead and involved tissue. Well, now we have some dead and involved tissue. So we've done a resection, and to get soft tissue cover and to deliver local antibiotics. And here was our medial and lateral gastroc flaps, and there was our antibiotic spacer. And we tried to go forward with the Masquelet technique. Peter Giannudis just gave a wonderful talk on the ins and outs of Masquelet, and I think that it does have advantages. And here, if we could have created a good environment, a local environment with a membrane and gotten the infection under control, that would have been a good option for this man. But unfortunately, that bone in back was too heavily contaminated and involved. And even though I tried to preserve it, in the end, I decided, no, the infection was not able to be adequately controlled. So here we just did a segmental resection, and he ends up with this defect. Now, this frame was applied with the bone largely intact. So you will see where that transport goes. It doesn't go where you might expect it to. And I know that you'll look at it and everyone's going to think that I've made it deviate. But in fact, this bone the frame was applied with the bone intact. So we've only transported straight up 8 centimeters. That's the bone defect we have now. We did a distal corticotomy, and distally I don't do a Jiggly saw corticotomy. I almost always will do a Jiggly saw corticotomy proximally, but distally we don't have as good success. So here we did the De Bastiani type technique of multiple drill holes, gradual distraction. We go slower than we would proximally. And here I think we might have gone 2/3 of a millimeter a day, just a little bit slower. But he formed very nice bone, probably because he's got a head injury. And so as we pulled it apart, lots of bone formation. And there it looks like it's really quite medial, but in fact, it's just gone straight up and hasn't curved back over. Normally the tibia has a little bit of a curve at the top, and so we don't have that curve anymore. And there he is. It took him 8 months to go 8 centimeters, so a month per centimeter, as you would expect. And pretty good cosmesis, lines up pretty well. And in fact, in the long-standing film, he is 0.8 of a degree different from his other side. So in fact, his alignment is essentially exactly the same as his intact side. He did end up a few centimeters short because his wife did not like the frame being on for such a long period of time and felt like 8 centimeters was all she could tolerate going. But that's the choice that she's made. Now, what do we do differently in 2021? How would I approach this any differently? We do a lot of the same things. We still do Ilizarov technique. We often do Ilizarov technique, though, with totally implantable nails. And I'll devote the next talk more to how we manage the defect itself. But how do we even assess it? We have a classification scheme, and this just came out just in the last couple months, and it's a way of looking at how you approach a bone defect. So up until now, because I got annoyed with the literature that there was lots of papers that said, oh, this is a massive defect, it's 4 centimeters, it's massive. This is a 3 centimeter defect, it's a massive defect. These are not massive defects, and if you deal with massive defects, massive defects are truly massive. So now we have a definition, and so this fits into the open fracture classification scheme from the OTA, and it's the classification is the D extension, meaning defect, and the D1s are incomplete. The D2 is subcritical, meaning less than 2 centimeter defect, and the D3 is more than 2 centimeters. And then from 2 to 4 is a moderate sized defect. 4 to 8 is a major defect, and 8 or more than 8 centimeters, we would call massive. So here we have, you take the longest measurement on the AP, the longest and the shortest measurement across there, and the longest and the shortest measurement across the gap on the lateral, and then you take the mean of all 4, and here it came out that it's 6.7 centimeters. So this is a major defect. It's between 4 and 8 centimeters. It's very clear. Now, we measure the volume of the defect to the millimeter. We want to know exactly how much it is, because I need to plan and determine the volume of bone graft needed. So we fill it up with saline. And this works best with subsegmental defects, but you can do it with a segmental defect if you have a defect there. The other way to do it is to put the antibiotic spacer in, and then when you take the antibiotic spacer out, take all of the cement and put it into a bit of saline, some kind of syringe with saline, and you can actually measure this displacement of the saline and also determine to the milliliter rather, how much bone graft you're going to need. But I'd like to know ahead of time, do I need, in this case, we needed 30 cc's, but do I need 10 cc's? Do I need 18 cc's? Do I need 75 cc's? It helps me plan out where I'm going to get bone graft from. And segmental bone defects, again, I'm going to have a whole talk just devoted to segmental bone defects, but this is very complex decision making. You're looking at bone and soft tissue defects, and whether it's acute or chronic or infected, and the size of the defect, not just the length, but the volume of the defect, and whether it's complete or incomplete. And it even matters whether it's diaphyseal or metaphyseal, and whether it's femur or tibia. You have a little bit different approach in various things. So it's relatively complex decision making. And here you see a mid-diaphyseal tibial defect. Well, you could approach that differently than you could a very distal tibial defect. The mid-diaphyseal one works very, very well with the new bone transport nails that are available, the implantable magnetically controlled telescopic nails, whereas the very distal ones are not amenable to that at all. And that femoral defect, that you could never use a transport nail. There you need to use something entirely different. So also you need to put in, patient expectations and motivation, and what the hospital resources are and what your skills are and your experience and things. So it's a bit of a complicated thing. I think there are lots of new things. Peter did such a great job describing everything to do with the Masquelet technique, but there's also a lot of new transport alternatives, and I'll go into all those, but this is just to highlight again, Masquelet technique, yes, it is an option. But within bone transport, we have at least 10 different methods that are different ways of doing bone transport. There's conventional Ilzarov, there's unilateral rails that lots of people have used for a long time. John Sontich talks about doing 2 hexapods, which I think is a very heavy fixator and very expensive. It's like twice as expensive because it's 2 spatial frames or 2 hexapods. And there are a number of different people that have come up with different ways to use cables. Metin Kushkaya in Istanbul has worked out a way. Steve Quinnen has a very nice method from Miami, the balance cable that he has talked about, and has really been a very good way to do things. And there's telescopic nails that have come out now, and Christian Kredic has created a way to modify a standard lengthening nail. And finally, there's this plate-assisted bone segment transport. And I will show examples of all these cases in the talk that I give in just a few minutes on bone defects. So we will just show, there was, I showed quickly a balance cable. That is an example of a balance cable. That is an example of a bone plate assisted, where you plate it out to length and use a regular lengthening nail, a telescopic nail, to do the transport adjacent to the plate. And finally, there's a real transport nail. So I have experience using all these various techniques, and we'll share a bit of that with you in the next talk devoted to just segmental defects. Thank you. Not sure what I did with the time there.
Thank you very much, Professor Kevin, because actually you gave a wonderful trailer also, so people will be really glued to see the segmental defect. So now it's turn of Dr. Ritab, and I'm extremely sorry, Ritab, I invited you a little early, But is the right time for you to start now, Ritabji?
Thank you.
And
Thank
Kevin,
you.
sir, you will be talking next.
Yeah, and my talk is essentially just a resident notes of all that has been spoken before by the eminent speakers, Dr. Gianardis and Dr. Kevin. So, infection after fracture fixation was the talk given to me. And if one looks at IAFF acronym on the Google, the first term that comes out is International Association of Firefighters. And tackling this condition is just akin to fighting with fire. And the current accepted terminology for infections following trauma and surgery is fracture-related infection, FRI. So like it has been alluded to that it's an undesirable and challenging complication. Most of the patients would require more than 2 surgeries. It's financially draining, especially in our situation, which is resource scarce. And there is a serious threat to limb survival, despite the best of efforts. So is it different from prosthetic joint infections? The answer, most of the surgeries in trauma after open injuries are done in an emergency situation where the soft tissue viability is variable. There are frequent visits to the OR, and there is an unstable situation. So the rates of infection are pretty high, especially after open fractures and compartment syndrome. So the answer is yes. The principles of PJI, prosthetic joint infection, can't be extrapolated to infection after fracture fixations. So if we look at the pathogenesis, the number of bacteria outnumber the human cells by a factor of 10. So why is infection so uncommon? This is because of a symbiotic relation between the bacteria and the living cells. Unfortunately, trauma and the subsequent surgery, use of implant upset this harmony. There is a complex interplay of bacteria and the host, the virulence of the microbe, the defense mechanisms of the host, the local environment conditions, and the use of hardware, which reduces the inoculum threshold for causing infection, all have a complex interplay, and this is an undesirable outcome. As it has been talked about, biofilm, essentially it is a race for the surface, and the bacteria would like to survive too, and they adhere to non-vital soft tissue, non-vital bone, and the avital implant that is being used. So biofilm formation is the bacteria's adaptation to survive in a hostile environment. And most of the times the infection is polymicrobial. What does biofilm do? It basically enhances the bacteria's resistance to antibiotics. So giving antibiotics alone is not a solution. And giving antibiotics, masking the symptoms, is a recipe for chronicity. So this is an example of biofilm on the humeral bone. So workup has been spoken about a lot, and the essential aim is to classify the patient and to get a roadmap to recovery. There are confirmatory criteria and certain suggestive criteria as suggested in this wonderful article. These are the criteria, and these are the suggestive criteria. So when we classify infection, there is a tendency to go in early, a delayed category, and a late category. So if we see in the early category, bone remains healthy and the biofilm is immature, and the results of good debridement are far better than tackling the same situation in a late scenario. So in the acute scenario, the classical signs are obvious and the diagnosis is not an issue. The laboratory parameters are numerous, but they are important for monitoring the outcomes of management and not for the diagnosis. The diagnosis gold standard remains culture. And culture is not only the normal gram stain and culture that we expect in 3 days. The sample should be sent for broth culture and we must wait for 2 weeks before ruling out no growth. One of the most common reasons for getting no growth is we stop at 3 days. As has been previously spoken, I'm just repeating. Repeating improves the retention ability of the audience, I hope. So needle biopsies, wound swabs are not recommended any longer. We must take tissue of at least 1 square centimeter from at least 3 to 6 different sites in the wound, above the plate, below the plate, between the plate and bone. So imaging gives us information on the anatomy of the bone, the position of the implants, the alignment, and the status of fracture healing. Higher investigations further help delineate the bony anatomy much clearer. One can see sequestra floating in the wound. MRI definitely is extremely sensitive, but its limitation is in the presence of implant, where artifact generation is significant. Nuclear imaging has a role, but it has a high rate of false positive results in trauma. So advanced imaging is probably more important in the chronic cases rather than the acute infections. The theme of treatment is either we suppress infection or eradicate it, allow the fracture to heal, and restore function. So the strategies are 2: union first strategy or infection elimination first strategy. In union first, we help achieve bone union and then consider removal of the implant, which may help eradicate the infection. Or the second priority is we eradicate the infection aggressively and then aim for bone union. Both strategies are equally effective, and it depends from person to person, patient to patient. What is most important here is the physiology of the host. If we have a young host with good defense mechanisms, good vascularity, one can be aggressive in the surgical options. Someone middle-aged elderly with diabetes and other comorbidities with reduced local vascularity, the outcomes are going to be inferior, and one has to ponder on whether 3, 4, 5 surgeries are wise or not. And if we have a status C host, the treatment should not be worse than the disease. And we should think of more dramatic options in such cases rather than reconstruction. So the principles I have simplified according to my understanding as ABCD: antibiotics, bone stability, cover of the wound, and debridement and irrigation. So at the center remains nutrition. Most of these patients have been operated a few times and generally are malnourished. So we must focus on the nutritional status of such patients. So we talk of antibiotics, they could be local and systemic, like Dr. Tetsworth has alluded quite in detail on the role of antibiotics. Antibiotics can be given intravenous or oral. Giving intravenous for long durations is probably not practical in our country. So it's equally effective if we can switch to oral as soon as the patient can tolerate them. Local antibiotics have their benefit. They deliver high concentration of antibiotic locally, far higher than the MIC. And even if the culture reports come out resistant to the antibiotics locally can tackle the bacteria. So we need heat stable antibiotics, and there is a lot of debate on what to mix. And like Dr. Tetsworth has said, adding 2 grams of vancomycin would lead to elution for 10 days, and above 3 grams would make it 60 days, which is more than adequate. So the aim is to suppress the infection, not eradicate it, if there is an implant in place. Regarding the question of bone implant to retain or remove, there are 3 fundamental questions. Is the stability provided? What's the location of the fracture? And what is the implant type? So if the implant is doing its job, we must try to retain it. If it's failed, there's no point in retaining it. If it's an intra-articular fracture that has been fixed well, it makes sense to retain the implant. And if it's a diphyseal fracture, one may think of revising it. If it's a plate it may be wise to retain it in acute cases. If it's a nail, one can go for removal and exchange in the acute scenario. Again, it depends from case to case. But acute hardware removal or change is generally not advisable. The options to cover the wound start from secondary closure to use of vacuum-assisted closure, flap covers, and muscle flaps locally. Debridement. The first aim of debridement is to harvest tissue for culture. A lot has been spoken about debridement, and probably this is the most important line in this slide, that the quality of debridement remains the most vital variable in the outcomes of the interventions. So the take-home message is that every case is unique and the implications are equally devastating. The diagnosis generally is not challenging. Elimination of infection is possible, but not always the primary goal. Radical debridement remains critical. Antibiotics are not curative with implant in situ. And bone union with function is achievable. It needs a team effort. Thank you.
Thank you very much, Dr. Ridhav Kumar. That was a wonderful talk. Can I invite for the last talk of the day, Dr. Kevin Tetsworth on new options in addressing segmental defects.
Okay, well, as we prepare, that was a wonderfully organized lecture. I really enjoyed the last talk. It was very nice, a really good
Thank you.
Summation. Very, very well done. Okay, I'm sharing. Good. All right. Well, we're going to explore some of those things that I alluded to, the various options for dealing with segmental defects. And I'll just talk about bone transport alternatives. I'm not going to get into cages and different vascularized bone options and things, which I think do have a role, but a more limited role. I think that the real workhorse in current treatment for bone defects is either masculae or a bone transport type of situation. And Dr. Giannoutis, Professor Giannoutis, has really covered the first option, the masculae, which I think is really a good option if you don't have the skills or don't have the resources available to do these fancy sort of transport things. It is a good option, but I don't think it's as good overall. I think the outcome, the bone quality is not as good, but that's personal opinion. Now, that's an example, just a quick one of a balanced cable. Steve Quinnan came up with this in Miami, and it's a very simple frame. There's only fixation at the top, fixation at the bottom, and the cable is attached and moves that piece down without disturbing the soft tissues very much. Another option is this plate assisted that I alluded to earlier. And here you have to have a plate that spans all the way from the top to the bottom. And then you'll see in the middle, there's a transport nail or a standard lengthening nail. You just lengthen that short bit of proximal bone there and transport it down. And the plate actually is very useful there. And finally, again, we'll go into these in greater detail, but this is the precise NuVasive type of magnetically powered bone transport nail that right now, as of this date, is currently removed from the market. It's on hold. It had some sort of regulatory issues in the UK. In the US, you can still use it. In certain parts of the world, Germany, you can still use it. In Australia and the UK, I think it currently is restricted. So there's all these different methods, and all these different people have come up with at least 10 different ways to do bone transports. And all of this has happened in the last 15 years, really. 15 years ago, there was either conventional transport with Ilzarov or unilateral rail. And again, the decision-making for these is complex. And, you have to consider the patient, the defect, you, and your resources. And there's a lot of specifics go into it and how you're going to approach the problem and things involving which bone it is, what the size of the defect, patient expectations, motivation, cost, all these sort of things. So even the social situation, someone in prison, for instance, or someone who's on their own, a single person, would really struggle with an external fixator for a long time. If you have to put a circular frame on and do a transport in a femur in an adult man who lives by himself, for a 10 centimeter defect, this would be very, very hard. Even putting clothes on in Western civilization and in the Western world, putting on pants and clothes and going to work and things is virtually impossible with a frame on your thigh. So this is very hard to do. Now we have all these different options available. Standard cancellous grafts have worked for years, for many years, and doing other things like the Huntington procedure, doing a fibula pro tibia, still an option. Segmental allograft, we don't use very often in infections. It's more commonly used in tumors and things. And even that has now gone to being augmented with a vascularized graft. A vascularized fibula often sits inside a big segmental allograft. And Ilizarov methods, again, have worked for years and years, for decades, for 50 years now or more. Bone transport, Ilizarov's method of bone transport or acute shortening and lengthening, it's a spectacular way to do it. Free fibula, I think, has a role, but I think a more limited role. We use it in the upper extremity for clavicle, for things like this. Not so much, because when it's a weight-bearing bone, it takes at least 2 years for it to mature enough to be able to walk unaided without braces and things. Masculate technique has revolutionized things in the sense of it's brought the ability to reconstruct defects to all those people that don't know Ilizarov methods or that don't have Ilizarov fixators available. So if you don't have the resources or that skill set, instead your skill set is putting in IM nails, putting in plates, treating fractures, doing bone grafts, this many surgeons can do. So it's broadened the number of surgeons who can approach these problems, and it's a very user-friendly sort of option. And finally, we'll go into these new transport alternatives. And again, I won't belabor the point with the various technicalities of the induced membrane technique. So let's say you have a defect for whatever reason, tumor, trauma, infection in a tibia. You can either do a transport, which means keep it at its original length and gradually move a piece down and grow bone behind using distraction osteogenesis. This is the classic bone transport with an Ilizarov frame, and it works beautifully. And it basically is as if that piece of bone is an elevator car moving down the shaft. Alternatively, if you did an acute shortening, so there you have distraction proximally, distraction and compression distally. So it's a bifocal osteosynthesis. Acute shortening is the same thing, but instead you do the compression initially and then you distract. So it's bifocal osteosynthesis, but it's compression and then distraction and the lengthening. So that is applicable in certain instances. I think in the tibia, normally up to 3 centimeters, certainly acute shortening and lengthening is preferred. More than 5 centimeters, transport is preferred. And really up to about 4 centimeters, you may get away with acute shortening. Beyond 4 centimeters, probably less likely to do so, but it depends on the location specifically and the local soft tissues and things. Now, this was a paper we put in injury, and Cengiz Shen was our fellow for a while, and he put together a lot of data, and we put together with the group in Baltimore and things, bone transport versus acute shortening. And it turned out that, in fact, there was very little difference, that the overall outcome was very similar. There were some slight advantages in the acute shortening group, but it wasn't dramatic. And in fact, the overall treatment time was very similar. It was about 1.74 months per centimeter in the acute shortening group and 1.78 months per centimeter in the transport group. So essentially the same external fixation time. Again, my fellow Konstantin from Austria came and we wrote up the technique of Ilizarov fixer, the standard sort of technique, but we won't go into a lot of that here. Here is a case, again, neglected trauma and open fracture, a guy that was ignored or off in a hospital 600 kilometers away, difficult to get him transported for various reasons. When he finally arrived, by then the bone has become desiccated and more infection than it was originally. And so he ended up with a 6.3 centimeter defect. And now we use the fracture classification scheme. So it's a D3B, it's a major defect. And this was his transport. So we kept him the length he was too big a defect to acutely shorten. So he's transported 6.3 centimeters. He's made good bone distally. He's done a docking site, good bone proximally, docking site distally, bone grafted that in a second stage. And that was at 11 years follow-up. He was good, solid. and well-healed bone. Alternatively, you could do this all with a unilateral fixer. I don't have a lot of experience in doing that. I have a friend in Barcelona, Pablo Corona, who does quite a bit of it, and they have an exhibit in their hospital for antiquated equipment, and it's all the Ilizarov gear, and instead they use these unilateral frames quite effectively. I mentioned earlier John Sontich, a friend of mine from the Cleveland Clinic in Cleveland, in Ohio, who uses 2 hexapods, but I think it's heavy and expensive, but it works very, very well, and he's done many cases, almost 100 cases with this method. He's reported on 60 some odd, 67 I think that he reported on, but yeah, he has had a lot of success using this method. So you gradually distract at one and you gradually compress at the other. So it's still bifocal compression distraction, just the same thing. That's Michael Weber, and he described using a cable and a very simple description in an abstract, but it never went any further. But all of these people in this picture, Steve Quinnen, Rainier Baumgart, and Metin Kushkaya, they have all written papers and described techniques for using cables for doing transport. And Metin from Istanbul has described, he creates a little bit of a fulcrum. He makes a pin but it's outside the bone, and the cable spins around it. I know it's hard to make out. You'd have to study these for some period of time, but on the bottom of these, in the lower right-hand corner of the screen, and it goes around a pulley here, and it's held off by. He makes a little track in the pin that it keeps it in line, and that's the real key. Is this pin right here? This one, I don't know if you can see my cursor, but it spins around this point. And in fact, this later on became, Peter Thaler and his friend Julian Formetz in Munich have used almost the identical technique and published on that. But Steve created this balance cable. I think this has really opened the opportunity for lots of other people to get involved doing transport now, because he's had such great success with it. And what's balanced is that he makes a focal pin here. There's right in the bottom in this distal segment, if you see my cursor here, there is a focal point. And I will use just a bicortical screw here, but the cable goes through the proximal segment. So here's the corticotomy proximally, here's the cable here, and one end of the cable goes around this direction. Whoops, sorry, I'll go back one. And one end goes the other way. And so they are balanced in the sense that they are each pulling the same amount. And so the force on this pin is balanced by the cable pulling one direction and one the other, and it makes it a focal point and allows this to simply pull straight down, and it can only go one direction, and the transport ends up docking almost perfectly. And he now has mated this up with, he does what's called cable transport and then nailing. I can't remember what the specific mnemonic is for it, but yeah, it's cable transport, balanced cable transport, BCTN, I think, balanced cable and then nailing, yeah. And this is a case that I've done, and again, it's about an 9.5 centimeter defect here in this one, so it's a D3C defect. It's more than 8 centimeters, so it's a massive bone defect. And after we completed the transport, at the docking site, we put a unicortical plate to hold it down there. But then you convert over and you put a nail down. So you can safely put a nail down because there's very limited fixation proximally, very limited fixation distally. The pins don't pull through this segment, so they don't tear through the skin here and create infections and things. And instead, the cable pulls very smoothly just out. If you see where my cursor is, these big white things are pulleys, and the cable comes directly straight out. And so you get no pin infection where this cable pulls out of the skin. And it's very safe to convert over immediately once you've completed the transport and do a nailing. Alternatively, you can use all internal type devices, and the Fitbone crew out of Munich, again, Rainer Baumgart and Augustine Betz invented this some time ago, but it was expensive and they limited the distribution, and only now are trying to catch up because other people are developing these things. But they call this the tibia segment actuator. So this is a Fitbone TSA, this is a relatively small defect. We call this a minor bone defect. It's 2.8 centimeters. And so it's D3A, but a smaller defect. Now, Rob Rosbrook and his friends, Austin Fragman and Mitch Bernstein, they're at HSS in New York, and they have published another technique of transport, cable-assisted transport over nail. And he tells me that this YouTube video that he has, the video, you can watch it on YouTube, and it's been seen over 3 million times. So it's quite a popular video. I think certain people are probably watching it again and again. I don't think there's 3 million even people that are interested in doing this technique. But the cable slides it over the nail, and the nails are. And one key is to have a little hole already drilled in the nail here. You have to make a special hole here so you can lock that piece once it's made the transport. Chris Creddick did a really clever thing where he just took a standard magnetic nail, a precise nail, and then made his own little tube for the end. So he made it into a transport nail. He's just added this segment here, if you see in these pictures at the bottom where my cursor is. So it's just adding a tube to the end of the nail and sticking it on the end of the regular precise transport, regular precise lengthening nail, and makes it into a transport nail. It's actually very, very clever. And we have done quite a few of those cases now myself. Plate-assisted transport, you have to get a plate that goes all the way from top to the bottom. Matt Gardner, I think, initially came up with this idea, but here is a case where we had, was a congenital pseudarthrosis. We've resected this about a 4 centimeter, I think 4.8 centimeter defect we end up with. The plate has to span all the way from the top and then all the way from the bottom, all the way above the level of the corticotomy. But the nice thing is that all these holes here, if you need to do any sort of interim step, you have something that you can lock that the transported piece in place and recharge the nail. It's called. You can make the nail go down 5 centimeters, put a screw in here and hold it in position, and then recharge and back the nail up and go another 5 centimeters. So theoretically, you can go long distances with this plate-assisted technique, and that's the real advantage to it. But here we used it successfully. We've done a few of these cases like this, and the plate that's already there acts to hold the segment down, so you don't need to have a hole in this nail ahead of time. And finally, this is doing one of these, what's called CKTST, which is Christian Creddick's transport segment tube, basically. And this was an infected non-union of a distal tibia. Unfortunately, I don't have any other x-rays of this from pre-op other than the intraoperative fluoroscopy. But we created a defect, not a giant defect, 3.3 centimeters. So I'd call this a moderate-sized defect, not minor defect, but a moderate-sized defect. And when we create these custom nails, we make the nail and make a standard precise nail into a transport nail, because this is only about 1 centimeter here, and they wouldn't give us the transport tube, the official transport nail, they wouldn't allow us to use, unfortunately. So, and in the technique, I use a jiggly saw, cut 80% of the way through, and then put the nail down, and then complete the corticotomy after it's locked above and below, etc. So this also actually works beautifully. And here, this is an application that they don't have an official transport nail. The precise nuvasive nail does not allow you to use it in this indication. So we create some custom tubes and just stick a standard precise nail inside. And finally, there is the nuvasive precise nail. And I know that I'm running long, so I won't belabor the point, but it's very critical, the position of the corticotomy relative to where your screws are. And there are times when this distance here is only 15 millimeters that you have to get your corticotomy in this exact location. So 15 millimeters, meaning you can vary about 4 or 5 millimeters either direction before you are running into trouble. So you have to be very exact with where you place your corticotomy if you are able to use and have access to use of this nail. That becomes the most critical component. And so I think this is the last case I'm going to show. This was a guy that was a 3C open tibia fracture. We shortened him 4.5 centimeters so that they could do a vascular repair. So he had blown out some vessel, his posterior tibial vessel there. So we shortened him 4.5 centimeters. That let them do a primary connection, a primary reanastomosis, and then he was still a 6 centimeter defect. That's this bony, that's a spacer here, got a free flap, etc. In addition, and again, the corticotomy location, very exacting. I mean, in certain circumstances, depending on the size of the nail, you need to have this positioned exactly where it needs to go. And this was one of those situations. You can see that we had to put the corticotomy between this screw and this screw. So it was very, and so this one is not quite finished. It's a work in progress. But again, finally, these are all the various alternatives. I know I've covered a lot of ground, a lot of different things to consider, but these are the options. And all of this has really erupted in the last 10 years. Eight different new methods that have come about recently that I think is really exciting. And there's lots of different options for you to choose from currently. Thank you.
Thank you, Dr. Kevin, sir. And this was like icing on the cake. Wonderful. People have really stuck to our track. There are more than 650 people who are attending it. And we are number 2 in the whole conference which is going on. You stick around over there, sir. And may I request Dr. Peter also to join Kevin for conducting the case session. And Peter, you are the first one to show your case, sir. Please, handing over to you. Peter, can you share the screen?
Let's stop there.
I will try now. Share screen. Okay, I'm going to show a short case in the interest of time, so that the other speakers and particularly Kevin may want to share a case as well. So this is a case that involves a 50-year-old male that had reconstruction following a fracture of his calcaneum os calcis 4 years previously. He developed infection. He had removal of metal work. He had 4 previous debridements, but things didn't go well, and he was still having a sinus, and he was referred to the clinic for further management. So you can appreciate here the previous effort to control the infection, the state of the bone, and the fact that there is evidence that there is a lot of activity there. And you can see the microscopic picture, the discharging sinus, the erythema, and so on. He had been offered amputation, but he came for a second opinion. And here we can see this is now about 4 years going on and off on antibiotics. They never managed to get on top of the underlying deep-sighted infection. Before we did anything, it was quite imperative to be able to appreciate the blood supply to the foot, and you can see the arteriogram that it was obvious that both vessels were potent, and as such we decided to proceed with debridement of the soft tissue envelope of the bone, obviously, and then to reconstruct the anticipated soft tissue defect with a free tissue transfer. So let's go to the next slide. You can see here the exploration of the calcaneum, the debridement of the soft tissues, and you can see here also the debridement of what was left from his subtalar joint and the calcaneum. Obviously, it was not possible to remove everything, but I felt we had a very good control and healthy margins following this extensive kind of surgical intervention. And then he received a latissimus dorsi muscle flap. You can see a bit the bulk of the flap and the overall cosmetic, maybe ugliness at this moment of time. But over a period of time, the flap settled down, then it was reduced, and we managed to get on top of things. And 3 years down the line, there were no signs of ongoing infection, and the patient was very pleased with the outcome of what we did. And this is my case. I don't know whether you're going to go to the second case or pass back to the podium and ask maybe another faculty member to present the case. I'm happy either way.
This was a wonderful case, sir. And for the shortage of time, what we will do is I'll ask Dr. Shiva and Dr. Ritak to present their cases. And if people are still hanging around, we'll come back to you. Sure, we would like to have your case, definitely. So may I request Dr. Shiva, please take over. You can share the screen, sir.
Yes. Thank you, Dr. Dilip. You can see the screen now?
Definitely.
Yeah. So this is a case of a fractured distal humerus, which was treated with a flimsy plate initially, which went into failure. Again, treated with a Phylos in a reverse fashion for distal humerus. And unfortunately, that also went into non-union with the screw started breaking. That was the time I came into the picture. Let me ask what the panelists will say. Peter, what you'll do at this stage? It's not infected. It's a simple, clean case.
Yeah, well, obviously you need to remove the plates. You've got a defect there. It looks like there is a bit of bone that needs to be removed to get some health margins, and then to bone graft it and replate it. And I think that will do well.
Okay, fine. Kevin, you want to add anything? Are you going to do anything different?
Yeah, I think acute shortening, and I would generally do dual plate these.
Okay.
Which is often a role for dual plating.
How much in humerus acute shortening is accepted?
Certainly up to 4 centimeters is reasonable.
Yeah, then it is falls within that area. So what I did was, in this case, I did an acute shortening, freshening of the ends, did the nailing and augmentation plate with bone grafting. This is an immediate posterior picture. On the left, it is at 5 months. On the right, it is at 9 months, beautifully consolidated. This is the clinical function at the end. Thank you.
That's great. And may I request Dr. Ritak?
Yes. Thank you. So this is a 52-year-old lady who fell from height of about 5 feet and has an isolated right knee injury. No comorbidity other than the normal Indian middle-aged lady, a little on the obese side. So further images, and since there was blisters, we applied an external fixator, and this is her at day 17, showing skin amenable to operation. So skin had reepithelialized and she was in the OR. So this is what we did. We fixed her, and post-op day 4, on the day of discharge, she said she's not feeling good. The pain is tolerable. There is fever. The lab parameters sent by the residents don't show anything threatening. But the first complaint, I'm not feeling good, was what caught my eye. So let's see the operated limb and the surgical wound. So this is the operated limb. That's the lateral wound. That's the medial wound. So question is what to do. Give antibiotics, immobilize the leg in a plaster slab and do daily dressings. Send blood tests for the blood test to check out. Take a swab from the wound or take her back to the OT. So we took her back to the OT. This is the lateral wound. This is my friend doing the debridement. He's cleaning up the mess of what I did. So I always involve a colleague when something is not right. And This is my friend doing the debridement. So why do bacteria persist in a wound? Generally, there are three reservoirs. A biofilm that forms on the implant and dead tissue, an abscess communities within the soft tissue, and if left for long, the bacteria travel and occupy the canaliculi network, and that results in persistence of infection. So this is after debridement and VAC. 5 days after debridement, we get her back to the OR to do a relook debridement. That's the medial wound. So we finally close her primarily over flat drains and reapply the VAC. This is the patient at 8 months follow-up. The wounds have healed. She has reasonable return to function. The fracture has healed. So the take-home message is that we must acknowledge the problem of fracture-related infection and act fast, faster than the bacteria. If we think too much, the bacteria are going to overtake us. Debridement, as has been alluded to by all the 4 speakers before me, debridement is the key. And it has to be done by a senior surgeon. The antibiotics are useful. They are a useful adjunct, like in tumor surgery, and always a combination. As Dr. Kevin has repeatedly said, a combination, because bacteria are fast and will develop resistance to a single antibiotic very fast. Retain the implant if it's doing its job. Don't be in a rush to remove the implant. And a good outcome is possible. Thank you.
Thank you, Ritabji and Dr. Peter. Can you please quickly come with your case? Okay, start sharing your screen.
Okay.
I hope you people are not tired, huh? And it's past what time now?
I'm sure they are very much tired.
No, but they'll have to hang on for next 5 minutes, okay?
So this is a case of a male 69 years of age. He had an industrial accident, open right humeral diaphyseal complex fracture, open right forearm fracture as well. You can see here the extent of the bony and soft tissue injury. Initially was managed with damage control, as you can see. Then the forearm was plated and an X-fix was applied to the humerus. You can see the extent of the gap and the exposure of the bone. He had several trips to theater. He underwent skin grafting and a composite muscle flap to the humeral defect and open reduction, internal fixation with a plate. Nonetheless, 4 months later, he developed a discharging sinus, and as you can see, there was loosening of the fixation with osteolysis around the screws. He was referred to my clinic then, and you can see within 2 days after we evaluated the situation and became familiar with the history and the issues to address, the muscular technique was applied. An external fixator was used as a temporary means to provide stability and to control the infection. 8 weeks later, he underwent the second stage. You can see here the bone marrow aspiration from the pelvis, the rear remer to obtain a graft. So the X-fix was removed. You can see here the induction of the membrane, removal of the cement spacer, and then stabilization of the fracture and the implantation of the combinatory graft rear cells. And you can see here 2 months down the line the overall progression. However, at 5 months we thought he was doing well, but then he presented, you see, at 6 months, a month later, with he had some form of an accident, so he broke the plates, and it was clear that there was not enough ossification of the graft locally. So we had to take him back. A cause of failure, delayed mineralization of the graft, poor vascular bed, poor osteogenesis. I don't know whether the one plate was enough and my work length was adequate. The quality, the state of the bone as well, you can consider whether that was a parameter. This is how it looked when we went back, debrided it, replayed it, and on this occasion, a BMP2 growth factor was implanted. And then you can see here the soft tissues, and eventually he united 4 months later, as you can see here. So we had to go in twice, augment the plating, put a second plate and a growth factor to achieve the objective. But I have to say that he was pleased with the outcome and the fact that he remained free of infection. So thank you for that.
Thank you very much. Now, as we can see, questions. Dr. Shiva has asked me some questions, and I want to kind of give you from where I had taken pains to give you this kind of information. This is from global guidelines for prevention of surgical infection. And this is the elite board of members. On the right side, you can see over here, these are the people who had done the study of at least 10,000 situation. And this is the email ID. If at all anybody wants to ask a question, you may take a screenshot, otherwise in the group, or I'll ask the people. Even those who are attending this conference can please take a screenshot of this. And the glaring question Dr. Shiva has asked, that why should we use or should not use antimicrobial skin sealants? And it has been seen not only in children but in adults, all the cases, this does not help you at all. And it has been identified that the skin irritation and allergic reaction as possible harms associated with the use of antimicrobial sealants. Besides, they feel that it is market driven, so be careful. Same is the situation about special new kind of dressings which are available. We have to wait, and this is the opinion of this group which has done the study, global guidelines for the prevention of surgical site infection. And my friend Dr. Shobit had sent me these details earlier also. So if you want to give the blame, it is blame to him, but it may be a news, and I am sure I have really opened up the hornet's nest, but this is the fact, whether you like it or not.
Fine, fine. Thank you. Thank you.
But if anybody wants, they can always ask me, or I'll show you. You can take the screenshot of this.
Yes. I have a question to Dr. Kevin. He said he uses 3 grams of vancomycin with the bone cement. Is it 40 grams of bone cement? Because I find it, if I start adding more than 2 grams of bone cement, the doughy feeling I don't get, and it starts separating. It becomes powdery and making it, especially in nail, becomes difficult. It is okay for a masculine technique, but using it over the nail, it doesn't bind it. Anything here you have observed like that?
Yeah, I would agree. I think that right about the limit, the 3 grams, and especially when you add 3, if you just put 3 of Vanco in, you're good. But if you add 3 of Vanco and something else, it does become a bit too much for it. And so if you're making just a lump, or you're making some beads or something, putting it on a nail, it does become problematic. But you can still make a nail out of an Ilizarov threaded rod, or on a K-wire, or on a guide rod sort of guide wire sort of construct, but you can't put it onto an actual nail. Then it becomes too much antibiotic. You're exactly right. I'd agree.
You made a passing comment about the lady who had head injury and distal tibial fracture transportation. There you said that because of the head injury, the regen rate was in good quality, you said. But my question is, how many days this head injury will have a positive effect to give a good regenerate? Because you yourself operated almost after 3-4 months. So whether the head injury have anything to play at that time?
Yeah, I'm not sure how long it lasts because we do see it for a long time. And not that I have documented it in any way, but the best masculine cases also, they have head injuries. They form lots of good. So those distal femur cases with the head injuries are very good candidates for masculine.
Dr. Shivashankar, I work in a spinal injury center. So like head injury, chronic spinal cord injuries with spasticity, these patients, they may break their bones, but they heal very fast. And we have seen this even as long as 10 years post-spinal injury. So I believe if nature takes away something, it gives something in return. We just have to harness it.
Yeah.
Please feel free to ask questions.
Dr. Dr. Peter, in the calcaneum case that you showed, where you did a debridement and there was a cavity left behind, before the flap, did you fill it with a resorbable bone cement? Did you fill the cavity in the calcaneum?
No. After the debridement, he had a cement spacer inside until 3 days later when he got the flap. So when the flap was done, we just made sure that the muscle was inside the cavity to bring vascularity. So no.
Thank you.
Like every good thing must come to an end. Yes, Dr. Kevin.
I just have one quick question. I know that I probably asked Peter this before, but the timing of the masculae, and I think that a lot of people still adhere to this 3 to 4 weeks, and they tell me they must come back at 3 to 4 weeks because in the rabbits it was 3 to 4 weeks. And when you get there very early, there's not much of a membrane to work with. I'm sure it's very biologically active, but it's just hard to work with. And so we let the soft tissues dictate. And I think even in the JBJS review article, the last one that Alain Mascalet wrote with you, you do make that point that the soft tissue conditions dictate when you can go back and not necessarily the timing dictated by the biology or trying to maximize the growth factors and things. Any comment on that?
Yeah, that's correct, Kevin. On average, I think you need to go back at about 8 weeks. For tibia, I go a bit longer, particularly because there isn't enough muscle anteromedially, so you need to wait to be patient. I've gone back 6 months later, and you find a very mature membrane. And the argument to go early is the fact that it was shown in the rabbit model that this membrane secretes growth factors. But this is not a problem for me because I can augment my graft with cells. I can augment my graft with PRP. I can augment my graft with BMP2. So this argument that I go early because I can reach the maximum release of growth factors at 4 weeks, I don't think is valid, because if your membrane is not good to mobilize it and to bring good vascularity to the graft, is not going to work.
So it's a bit of a balance, the tissue handling and the biology. Yeah.
Exactly. And you, don't forget, you can influence the biology.
That's a good point. Very good.
Yeah, biology for me is not a problem. I think the issue is to have this a membrane to be able to mobilize it and create, this bioreactor, and then you can put whatever you want inside, and with the blood supply of the membrane, you've got a very good condition to see that kind of bridging effect to evolve and then to progress to this mineralization of the graft that we want to see.
We do have an ongoing study going. We have harvested specimens from about over 70 masculine membranes now, and we are looking at the biology and the upgrowth of the various growth factors, the upregulation, downregulation, and it seems to be very biologically active even at 20 weeks. It's still.
Yeah, I agree with you. Yeah.
What a healthy discussion. Two stalwarts are just arguing and then ultimately agreeing to it. Now, if we have to have any question, I will permit one question. Reddy, do you agree with this? Otherwise, we have to come conclusion.
Yeah, if any question is there, then we can. Otherwise, I think that was an excellent interactive session and a great talks as well as discussions. So probably we can end the session as Dr. Tetsworth, I think, is too late.
No, just give me 2 minutes. Just give me 2 minutes, sir. I must thank all of you because we had splendid speakers from all the corners of India. Dr. Shivashankar from Solapur, Dr. Rita from Delhi, Dr. KJ Reddy from Hyderabad, and myself, Dr. Dilip Shah from Mumbai. We had lots of lectures on infections and non-unions. How true it is that we learn when we try to teach. In fact, nobody was a teacher, nobody was a learner. We all were learners, and it's always me with you, speakers and delegates. We become we, because my happiness begins when I stopped thinking about me and started thinking in terms of we. It's a teamwork. All of us from India and the eminent speakers like Dr. Kevin Tetsworth from Australia. It must be around 2:30 or 3 a.m. And Dr. Peter, what time is it, sir?
2 in the morning.
2 in the morning. That's what I was thinking. And Dr. Peter Zenoidius from Leeds, United Kingdom. I'm really thankful on behalf of everybody. Thanks Integrace for integrating us gracefully. Thanks OTA, our torch to make us able. Thank you very much. Thanks a lot.